विकसित उत्तर प्रदेश के तहत जो यहाँ पे सेशन है, पैनल डिस्कशन है, वो डेटा ड्रिवन डिजिटल हेल्थ केयर एंड एआई इन हेल्थ केयर पे है। तो इस सेशन की हम शुरुआत करना चाहेंगे और सेशन की शुरुआत करने के लिए सेशन चेयर मॉडरेटर सचिव चिकित्सा स्वास्थ्य एवं परिवार कल्याण मिशन निदेशक आयुष्मान भारत डिजिटल मिशन श्रीमती ऋतु माहेश्वरी मैम को मैं स्टेज पे बुलाना चाहूँगा और इस सेशन का जो कॉन्टेक्स्ट सेटिंग है और जो इसकी आत्मा है उसके बारे में मैम हम लोगों को अवगत कराएंगी। मैम, डॉक्टर रीना से रिक्वेस्ट करूंगी कि मैम का स्वागत फ्लावर पार्ट दे के करें। ले लो। थैंक यू मैम।
Good afternoon, everyone. Today it's my privilege to welcome you all to this session on data-driven digital healthcare and the role of AI, a theme that truly sits at the core of collective aspiration of all of us for Viksit Uttar Pradesh 2047. We all are aware that UP is entering a defining era, the state with the largest population and one of the most diverse health needs in the country. UP today is uniquely positioned to demonstrate how digital infrastructure, how AI can reshape the entire healthcare ecosystem. If we see the state's performance over the past few years, state has built a very strong digital foundation and done commendable work in many of the areas, ranging from generation of more than 14.5 crore Abha IDs, registration of more than 72,000 health facilities, 1 lakh plus health professionals are already onboarded on national digital platforms. 12.5 crore plus digital health records have been linked to Abha IDs. We have 10 to 12 crore plus lab tests conducted every year. Now, also the reports being shared on WhatsApp or messages or on the health apps. 5 crore plus teleconsultations alone in the government sector through eSanjeevani, expanding rural access to specialist care. These numbers today highlight not only the scale, but also the vast opportunity to build AI powered data driven health systems. At the same time, UP still needs to address a lot of on ground challenges, constraints in the HR resources, constraints in IT infrastructure, low digital literacy, resistance to change, and of course, the significant costs associated with the large scale digital adoption. This makes simple, scalable, and interoperable solutions essential. The Ayushman Bharat Digital Mission, recently launched by Government of India a few years back, is therefore very important, providing the unified and the secure digital architecture needed for a state as diverse as Uttar Pradesh. Today, as we all sit together here, and most of you have attended the inaugural session also, so the state, in line with the national vision, is aiming to build its own vision for Viksit Uttar Pradesh 2047. Specifically for this session, when we talk about Viksit UP 2047, as I visualize and as we as a state visualize, we should have a state where every citizen has access to high quality, timely, and personalized healthcare powered by strong digital tools. Our healthcare systems, our techniques, our surgical methods should be more affordable, smarter, precise, and less painful. We aim to move from reactive treatment to proactive, preventive, AI driven healthcare. Every individual should have longitudinal health records through ABHA. Our all stakeholders, our hospitals, our diagnostic labs, supply chains, telemedicine platforms, all should be digitally connected. Equally, most important, we want a health workforce that feels empowered, not burdened, and supported by simple tools, strong data governance, and continuous digital training. This is the UP we aspire to build by 2047, a state with one of the most inclusive and citizen centric digital health systems. So, this is just a snapshot of what 2047 for data driven governance in healthcare could be for UP. In this context, we have a very long list of esteemed panelists today who have expertise in their own specific areas. And I believe the panel discussion, the open house discussion, which would happen today, would go a long way in building UP and taking it on the path to a digital transformation. Thank you, everyone, and welcome once again.
थैंक यू मैम। मैम कृपया स्थान ग्रहण करें। अब हम इस जो पैनल है उस पैनल के पैनलिस्ट को बुलाना चाहेंगे। सबसे पहले मैं ज्योति यादव मैम, जॉइंट सेक्रेटरी हैं गवर्नमेंट ऑफ इंडिया, मैम को आमंत्रित करता हूं स्टेज पे। मैम प्लीज आएं और विकास जी से रिक्वेस्ट करूंगा कि मैम को फ्लावर पार्ट देके मैम का स्वागत करें। थैंक यू मैम। इसी कड़ी में आगे मैं श्री पंकज कुमार अरोड़ा सर का स्वागत करना चाहूँगा और रुचि जी से रिक्वेस्ट करूँगा कि सर को फ्लावर पॉट देके सर का स्वागत करें। इस क्रम में अब मैं डॉक्टर देवेंद्र खंडैत साहब को इनवाइट करना चाहूँगा। सर डिप्टी डायरेक्टर कंट्री लीड स्टेट हेल्थ सिस्टम हैं गेट्स फाउंडेशन में, और धीरेन्द्र जी से रिक्वेस्ट करूँगा कि सर का स्वागत फ्लावर पॉट देके करें। थैंक यू। इसके बाद मैं विकल्प साहनी जी को बुलाना चाहूँगा। आप फाउंडर हैं, सीईओ हैं एका केयर के, और शिशिर जी से रिक्वेस्ट करूँगा कि वो फ्लावर पॉट देके सर का स्वागत करें। थैंक यू। इसके बाद मैं तन्मय सक्सेना साहब को बुलाना चाहूँगा। आप चीफ ऑपरेटिंग ऑफिसर हैं टाटा 1mg के, और जितेंद्र जी से रिक्वेस्ट करूँगा कि फ्लावर पॉट देके आपका स्वागत करें। इसके बाद मैं पी श्रीनिवासा सर को इनवाइट करना चाहूँगा। सर एसएस इनोवेशंस में सीनियर वाइस प्रेसिडेंट हैं, और मैं एस एन मिश्रा जी से रिक्वेस्ट करूँगा कि सर का फ्लावर पॉट देके स्वागत करें। हम लोगों के साथ एक पैनलिस्ट ऑनलाइन भी जुड़े हुए हैं। हम लोगों के साथ डॉक्टर सहाबत एस आजिम सर जुड़े हुए हैं। सर प्रशासनिक सेवा से भी हैं, सर डॉक्टर भी हैं, रेडियोलॉजिस्ट हैं, और इस समय सर फाउंडर और मैनेजिंग डायरेक्टर हैं ग्लोबल हेल्थ केयर के। तो सर का स्वागत है, मोस्ट वेलकम सर। अब मैं चेयर कम मॉडरेटर सचिव चिकित्सा स्वास्थ्य एवं परिवार कल्याण श्रीमती ऋतु माहेश्वरी मैम से रिक्वेस्ट करूंगा कि मैम इस पैनल का डिस्कशन स्टार्ट करें। थैंक यू।
थैंक यू मोहित जी। सो जैसा शुरुआत में बात हुई, हमारे पैनल में बहुत डाइवर्स पार्टिसिपेंट्स हैं, रेंजिंग फ्रॉम गवर्नमेंट ऑफ इंडिया टू स्पेशलिस्ट टू पॉलिसी मेकर्स. So I start the discussion today with Dr. Devin from Gates Foundation. Dr. Devin has been in the foundation and with other international organizations for a long time. So as we aim and visualize to move towards Viksit UP 2047, we are all well aware that global best practices can offer us valuable guidance. So, as per you, what lessons from global digital health programs can guide the state in enhancing real-time surveillance and evidence-based decision making?
Thank you, ma'am. And it's an absolute honor and privilege to be here. Um, I'm not the expert in the digital, but working in the public health for a pretty long time, I can safely say कि And this is not just because I work very closely with the government of Uttar Pradesh and government of Bihar, but but in the digital health ecosystem, UP has all the reasons guide the world. And when I say this, I say this with a lot of confidence. UP has taken significant fundamental steps over the last several years, which gives the promise that UP can, through its, and you name it, in the several areas, UP has demonstrated, whether it is a UDSP, whether it is e-Kavach, whether it is ABDM leadership, um, whether digital architecture, whether the way they have looked at it. Yeah. But of course, there is always a scope for learning from several several countries and several places जहां से तो मैं तो सिर्फ एक दो ही बार कुछ कहना चाहूंगा. So for example, in the area of API driven digital architecture, I think, and my always my go-to country for that matter very uniquely is Rwanda, which has um, which has OpenHIE Connect. Um, they have connected, they have used API and the data flows in a very seamless way. Uh, uh, Whether it is a Brazil, again the integration issue. At the end of the day, interoperability and the bidirectional API integration, bidirectionality of the API is going to be the key. And many times it not only remains that that challenge not only at for one state, it is the multi-state. Several initiatives in the continuum of care digitization. Um, uh, Again, several countries have done that, but I think the learning one can definitely say is one cannot think from an isolated way. How do we think from a journey from Asha to the final point at the hospital? And the countries, so there are several countries, Brazil, Rwanda, Estonia, there is a long list. Uh, but I think, and there is a powerful step UP has taken. Um, the only time I feel like one of the advantage of UP is operating at a scale instead of going for a small pilots. So continuum of care digitization is one. Um, the third point, and I will close that, is the capacity building at scale. Are we using effectively the AI and AI powered e-learning platforms? And for example, several countries have used that. Whether it is sufficient for certain skills and competencies, only digital platform may not be sufficient. But how do we use that technology in such a way that there is an advantage of AI digital tools, at the same time we can couple with that? And the lastly, I will say, finally, at the end of the day, it comes to the budget issue. For example, Brazil has put 200 million, they have earmarked for the primary healthcare digitization to ensure in-house capacity. Government of UP has done several steps. For example, their Hope Center, in a way, tries to bring several digital platforms at one place to help the different tiers of the government to take the decisions. Now, how do we use AI in such a way that it is not only compilation of data, but a smart analytics is there, and which can help to identify the epidemics, to identify the outbreaks, to identify the emergencies? How can we use that? I think there are a couple of things. Thank you.
So thank you, Devenji. And as you rightly said, interoperability and prioritizing the budget are two very important factors as we move ahead. So now moving on to Vikalp Ji, who represents Eka Care. So UP, we all are well aware that has huge challenges in terms of uneven levels of digital literacy, vast population, geographical diversity. You have been working quite well And I think as far as the generation of Abha IDs, linking of health records is concerned, what do you think? How can the state accelerate the awareness and adoption both of Abha linked health records, not only for citizens but also for healthcare perspectives, healthcare providers' perspective?
Um, Thank you, ma'am, for inviting. And first of all, I mean, being here in UP, I'm glad that I'm visiting. I'm from Bangalore. One of the things that I personally felt in UP, we see since last few years, uh, a thought on this bias for action, right? Things happen. Look at the number of scan and shares and how basically adoption is happening, which is great. And at the scale and diversity that you just mentioned, it's quite heartwarming to see. Uh, though what our observation when we work on the digital space, and we have two sides of stories that we solve for the customers. One is on the PHR, which is the personal health record. Patients can come, they can do scan and share, link their records. And on the other side, we have HMIS, who are linking records. Where we see many states have been able to successfully scale up is the administrative side of digitization, which is token creation, generating of scan and share, OPD parcha, so to say. But the real problem lies, and if you look at it, there are two sides of the problem in digitization. One is an administrative problem, which is also quite important. And the second is the clinical problem, where the outcome is important. So the sooner we start thinking of moving towards the clinical side of solutioning, the network effects will start kicking in. And I'll give an example in my previous company. So I was the co-founder CTO of Go Ibibo, where we were the one who wanted to start selling hotels online. And like pre Go Ibibo, the hotels were not sold online. The idea was how can we bring hotels? What do they care about? They care about patients or users who come and then they stay at the hotels. And what the users care about, the right kinds of hotel reviews, rating, what is it that they need. Obviously, there is an administrative burden which you can solve using software, but the crux lies in the clinical solution. And that is where the depth of capturing of clinical information comes in. Uh, our thesis is that if ABDM and the way we utilize the platform, if we start focusing more on the clinical side now from administrative, doctors will see a lot more value, that they are able to get far more information about the patient, and they are able to actually use the time. For example, is ABDM can capture before even the consultation some part of the digital health information and provide it in a structured way to the doctor. He will save the time. Also for patient, right now for them the whole point is that okay, yes, I get the token, but when my medical record, my longitudinal history starts coming in over there, I can see my kids vaccination chart over there. You would see that the adoption at the grassroots level will start happening more, where we will see now it's not a push but it's a pull. The people are asking that I want this data to be connected to my Abha address, and doctors would say that I would like to and so that would be the place where we have to go. I think the way to solve for this is actively working on the clinical data digitization, and thanks to AI and all, I think that's quite possible now. It's one of the hardest problem in the world. We also know that be it other countries as well, there's a lot of manual work that happens to capture clinical data. But now, if we go really aggressive in leveraging the technologies that are available to solve for the clinical data, I think the adoption curve will increase dramatically.
Yeah, thank you, Vikalji. And as you're rightly saying, capturing of data before the patient reaches the doctor is very critical to moving ahead in this entire digital journey. Moving on to Dr. Sabahat Azim, who is the founder of Local Healthcare Systems. I hope I'm audible. Dr.
Yes,
Azim.
yes, certainly I can hear you.
Yeah. Welcome once again. So, as we have been talking about UP, its vast geography, the scales involved here, what two, three, or four, or one digital or technology enabled care model do you believe UP must invest in today or next 3-4 years so that we have universal access to primary and preventive healthcare by 2047?
Thank you so much. First of all, thank you so much for inviting me and also allowing me to join digitally. Uh, Pleasure. Um, the first point that I would make is 2047. This is the first time, and I've been in public service for some years. This is the first time I'm seeing a perspective plan 20 years before, and that is very heartening. Generally, governments look at only 5 years when they're in power and see what can be done, but this is the first step. The second point, UP is bigger than almost 40% of the countries in the world. It would be the fifth largest nation in the world if it was independent. So it's a country in itself. So I would phrase my 3 points. One is that, we need to look absolutely afresh. Old order changeth, yielding place to new, lest one good custom should corrupt the world. Let's forget whatever we've been doing, and you have the opportunity, you have the size, you have the scale, you have the ability in terms of everything. Forget the problems. Problems are always an opportunity. If you create something today, thinking afresh, you can create and leapfrog. India's own leapfrogging today, you see, IT and IT services earn more export income than any other single export sector. And that has happened because of the telecom revolution. And this is where India actually marched ahead. You have the seed and the ground for creating something afresh. The other point I would make is, in this process of thinking afresh, I would suggest, or request a relook in terminologies. I think this primary, secondary, and tertiary, now quaternary, these frameworks are redundant. They actually make no sense. What you were saying, comprehensive or continuous, let's simply call it comprehensive care. I would say that the framework that I use is every healthcare service, infrastructure, financing can be divided in a grid of 2 by 2: acute, non acute, interventional, non interventional. Now, this is a long thing. I see Dr. Devendra Khandayat from BMGF here, and this is a separate longish discussion. You can actually divide the infrastructure that you want to put up based on these parameters, and it'll change everything. It'll make things simpler than the older terminologies that we have been historically using. The next point, and which is the main point, is that I think UP has the ability, the scale to think massive beyond even countries in itself. You are a nation in yourself. When you think of something, there are 4 steps that we think: strategy, structure, people, and process. I'm just going to focus on the structure part of it, which would be probably important if you want to lay the foundation of something better. The phygital infrastructure that you have or you want to create today is the time for you to think. And I would urge the state to think in these terms, that don't think of solutioning. Don't think of, whether it is a clinical experience or it is the background technology infrastructure that works. Think about laying out the infrastructure like a open source uh, framework which everybody can join in. So if you create a phygital infrastructure whereby all the data, whichever form it might be, forget about it's complete, it is incomplete, everybody can pool into it. For example, from your EMRs and the huge amount of work that you've already done, the episodes, the patient's EMR, the episodes, the events in his longitudinal life scan can be put into a single framework. Of course, you need to have a secure ID. Each of these are important and detailed topics in themselves, so I'm not going to waste time. Let's say, assuming that there is a ZKP or any other format of a secure HID available, which protects the patient's privacy, incomplete data, inconsistent data, doesn't matter, pool it into one source. Also get the health providers to Poland, which is already legally required, but nobody does that under Clinical Establishment Act. Put in every event, every episode, every intervention, every outcome from the pharmaceutical and public reporting, all the adverse drug reactions and complications into one framework. You have the legal provision for it, force it, but for that to actually work, you will have to decriminalize any data which is put into the system. Healthcare providers do not comply with the requirements of Clinical Establishment Act to put the data because there is a legal liability. The patient does not have his own health file, but the provider keeps it. It is ridiculous. It is very, very stone age. But the way forward is not by forcing or penalizing, it is by putting in a legal framework of decriminalizing the data which is inside, which means that people must be free to share the data, otherwise we won't be able to grow. Now, once you put an infrastructure which actually sources into one large pool, it doesn't matter what topology you use. Innovators will come and use that public data to develop hundreds and thousands. So what you're doing is you're sparkling a revolution, a health revolution, which means that you enable the data that which is needed for people to build their services around and make it open source. Let it be available to everybody, whoever wants to build a framework on top of it. You are bigger than Google Play Store and iTunes Store in itself if you just put your resources together. The uh, point I'm making, instead of trying to be a provisioning of services, you do your own provisioning of services, whatever you can, but make the data one single pool, a data lake or a swamp, whatever you like to call it or how you want to structure it. But make it available to everybody. Let people build their services, do an R&D. It's public data. It's a public good. So essentially, making public good the entire infrastructure framework for it, and decriminalize it so that people are actually free and forced to do it. Same way the government actually pours their epidemiology, their facilities, their manpower, everything into that database to build upon it. And the last point before we move on is to say that, we need to think is we need to stop thinking of monolithic structures where the government is the provider of services or the sole brain behind it. But you actually use it as a framework which is open to everybody and allow people to build services on top of it and let the market decide, or let the government or each local body decide what they want to use out of it, whatever other offerings. So it's an ecosystem, like a Play Store ecosystem, rather than a solution in itself. And the last small point I would make is that you see, you have the biggest look at electricity reforms, the division into the production, distribution, and transmission. Think of it in the healthcare space, the amount of infra, people, and services you have without taking away the rights of employees or the uniqueness of your department. You can actually take it to the highest level without the problem and the risk that Dr. Khandat was pointing out on the public spending. Public spending can increase by simply creating the appropriate financial structures on this physical network. I will get into it details if needed be, but I want to leave these initial thoughts first with you and not hog everybody's time. Thank you so much.
Yeah. So thank you, Dr. Azim, and we heard very insightful ideas on how do we take ahead the digital journey, and especially how the government and the healthcare providers in the private sector need to work together. So moving on to Mr. Tanmay, who represents Tata 1mg as a Chief Operating Officer, and chain has been working at quite a scale as far as the diagnostics are concerned. Uh, what do you think? How can technology-driven models be integrated into a PPP framework so that UP is able to build digital health innovations, especially in areas like home diagnostics, telepharmacy, or medicine demand forecasting, so that there is a broader alignment with the state's vision for 47?
Thank you, ma'am, for having me over in this distinguished panel. Uh, very pertinent, very important question, since this is a panel on AI and digital data and healthcare data and how that can be used to impact actually outcomes for patients. Uh, l- we have all kind of covered different aspects of it, availability of data, common lake access, portability, interoperability. I just want to sort of broadly divide how some of these large consumer platforms, digital consumer platforms, like my colleague here with Eka Care and Tata One MG, how are these relevant and how this eventually can turn into something very important and useful when it comes to even sort of private public partnerships. So the way I divided it is that I look at it uh, for this healthcare data, I break it down into three parts. First, there should be at least examples like these large consumer platforms and what the government can become. First of all, you need to have large amounts of data which is relevant, based on which you can actually draw meaningful insights. Right now there are very few such channels and opportunities because there are either sub pools or insulated sort of uh, catchments of data which are not working together to actually help draw insights, right? So one of the advantages of us having a large enough consumer platform is that we have about almost 35 to 40 million people, unique people visiting this platform, right? So 3 to 4 crores people using this sort of platform and doing their health care transactions on us. Like you mentioned, diagnostics, for example, almost 500,000 to 250,000 to 500,000 transactions. And then the same folks buy drugs, medicines, whether they're chronic patients or acute patients. And what we are trying to do is that put together all of this digital footprint in terms of maybe longitudinal data on biomarkers, your lipid profile, HbA1c, and your usage of drug, whether the strength has improved, decreased, not decreased. And all of this valuable information, we are trying to sort of draw insights. And even the browsing, for example, we have seen that we get early detection if searches for certain kinds of products start increasing, and we can identify it to cities, we can identify it to zip codes if there is some sort of a fever or a flu happening before time. Now all of this is happening within our platform. We are providing longitudinal insights for patients for their long-term health history. How is this relevant, at least when we partner with government, is that this is exactly the kind of population statistics which probably the government would need for making policy decisions, for identifying pockets where health related issues are emerging even before they start spreading into the population, right? And this is where platforms like ours or any large consumer platform becomes very helpful, because you can get this data, you can get very precise data. At a statistical level, you can start identifying patterns. And diagnostics is just one part of it. We even have drug consumption data, we even have browsing data. All of this together can be put into really meaningful, insightful interventions, and it can also help and influence policy making as we are thinking about, the eventual ultimate outcome for patients, which is basically health outcomes for them. So that's at least some of my views.
So thank you, Tanmay, and you have also raised very valid pointers on how do we take ahead this journey. Now, moving on to Mr. Srinivas from SS Innovation, and they have done wonderful work so far as surgical robotics is concerned. So, as we are moving ahead and preparing the state for a future where precision medicine redefines clinical care, how do you think will AI enabled surgeries reshape UP surgical landscape? What kind of investments would be needed to match that reshaping so that we are able to reach that vision of 2047?
Thank you, ma'am. And first of all, it's my honor and privilege to be part of this important panel. Uh, well, all of you are aware that medical technology will play a very significant role in relation to the healthcare delivery and success of the healthcare outcomes. And especially when it comes to the high-end medical technology, it is always unfortunately limited to the Metro One city hospitals and some of the top medical colleges, or for that matter, only the private hospitals are affordable due to mainly the capital investment. But when it comes to the even in the government medical colleges or tertiary care hospitals, if you see for the last 10 years or 15 years trajectory, that the availability of the high-end medical technology is always limited, right? There will be always a reference to the private hospitals, be it is a radiology or whether it is a diagnostic center or whatever it is. But significantly, for the last 10 years, the government had come up with a very unique model in relation to the public-private partnership models. Rather than investing huge investment in relation to this high-end medical technology, and then today we all have witnessed the programs like teleradiology, teleophthalmology, telemedicine, telediagnostic center. There's a huge success in the government platforms where the government actually can save a huge capital investment, but where at the similarly that they can provide the high-end technology and high-end precision, the healthcare to the patients who is visiting to the government hospitals. So when it comes to the robotic surgery is where we comes from, which we always feel like it's very important and it's the right time for India also to adopt the robotic surgery. But unfortunately, because of the higher cost which are required to acquire this robotic system, India has not seen a significant evolution in relation to the adopting the robotic surgery. Well, many of you are aware that globally there's only one company who have been available for the past 25 years. And India with a significant spent on the healthcare, but today, I mean to say at least for the last 2 years back, India with a 1.4 population that we had only in 180 robotic systems, and which is very significantly less compared to when you compare with the United States, Europe, and for that matter, China and Japan. So ultimately, the technology has to be more affordable in relation to cater it needs to the government hospitals. It cannot be always limited to the private hospitals. So the catering to the high-end technology to the government hospitals, that's only possible when somebody brings an affordable technology and it will be more accessible. So we as a company that we have built a 100% indigenously developed robotic system, which has completely a digital dashboard, AI-driven tools, and a digital integration and telesurgery capabilities. And we are the only company today globally who have been approved for the remote surgery, madam. And I take this as an opportunity to let you know, madam, I am sure that whether you are aware or not. And Muradabad is the place who has done the first remote surgery in the UP. Well, of course, we have done 3, 4 surgeries before UP get into this remote surgery. And it's a proud moment for all of us. A surgeon sitting in Delhi and operating on his patient in a hospital in a Muradabad. It's a huge milestone. See, we are today talking about the 2047, but the opportunity is still, lies with us for the next 5 to 10 years. But we need a good ecosystem in relation to the industry and healthcare department. They should work together and work with the Indian companies where the affordable technologies are available so that can actually significantly scale up the government healthcare ecosystem. So when it comes to the PPP model, especially for the robotic surgery, well, I could see the success that we have seen in the teleradiology and telediagnostic center. I think the robotic surgery also can be a model which can be more successful if the government consider into a PPP model, because if you envisage the bringing the latest technology into hospitals, but investment towards to these capital investments are huge. But at the same time, whether these public procurement models will be as successful in robotic surgery, because unlike in telediagnostic and radiology where you can place a system which is a plug and play and a company can provide a technician or a radiologist, it's a easy. But when it comes to the robotic surgery, it's very important. There's a lot of stakeholders involved, right from the surgeon, assistant surgeon, and circulating nurse, scrub nurse, the instruments cleaning, CSSD. So it's a complete ecosystem, and we are playing with the patient and doing the surgery. And there will be a lot of mishap can happen if one cannot, practice properly during the interoperative. So we, government and the private companies, can actually think together in relation to how this public-private partnership model can be a more successful in the robotic surgery, that can actually provide a, the high-end quality of care to the patients. So if you see Uttar Pradesh as a landscape, that before we came into the picture, I think SGPGI is the only government hospitals for the last 25 years who has only one robotic system. But when we brought the affordable technology to India, and today within last 1.5 year, we have our robotic system even in tier 2, tier 3 cities, where it is providing the affordable robotic surgery to the rural patients. So that's where it matters. The providing a high technology healthcare to the rural population is very important. And we as a company, we had recently had come up with the telesurgery capabilities, madam. And as I told you, the surgeon sitting in our office and operating in patient versus now imagine the two hospitals, they were actually, exchanging the care, right? The example which I said in a Muradabad, it's like a small wife and husband hospital, a gynecologist and a general surgeon, where if the patients comes with the urology problems, right, and they don't have it, they have to unfortunately refer to the tier 1 cities or metro cities for a larger hospitals. So with this remote surgery capabilities, you don't believe that hospital has been partnered with another hospital in Hyderabad, and a surgeon, urology surgeon sitting in Hyderabad, and he has operated in a Muradabad. Similarly, in a Hyderabad patient hospital, it's a urology specialty specific hospital. A general surgeon sitting in Muradabad operated the hernia surgery in this thing. So what I'm trying to say, yes, the PPP model for robotic surgery, it's definitely is viable, and probably we should have a good stakeholders meeting to make sure, to build the infrastructure in relation to the planning and execution. Thank you.
So thank you, Srinivas ji. And I now move on to Jyoti ji, who is the Joint Secretary in Ministry of Health. And all of us sitting here are looking for a vision which is in line with the country's vision for Viksit India by 2047. So what do you think, what should be UP's unified digital health architecture? What should it look like in 2047 so that it is care?
Thank you, ma'am, and thank you for having me. It was pleasure listening to all my fellow panelists before me. And the question that you have asked, ma'am, uh, uh, there is an administrative flavor that I will add to that. First of all, the physical infrastructure is never going to be enough. So the digital infrastructure that we all are talking about is going to be the add-on, or both should complement each other, because one alone, either one of them alone can never suffice for our problem. So the 2047 vision that UP or a country is visualizing is the first and a very simple issue that any of us deal with sitting in this room is, let's say any of you have a headache or a body ache or a fever. You first think of a doctor friend or a doctor colleague or somebody who knows something about being a medical knowledge. So that in today's age or going forward, it's going to become much more easier that at your phone, you should be able to submit your symptoms and it should give you your clinical diagnosis to begin with. And that with that, you should be able to see a choice of doctors, choice of hospitals where you can go. It can be both in public and private. So let's say if I feel any symptoms, I should be given a choice whether you want to visit a whether there is a need at all to visit a doctor, or is it like these are the recommended medicine by the medical science, you can take that at home, the recommended dosage can come, and whether there is a need to see a specialist as a screening or preliminary diagnosis of that. And then I should be directed to a doctor, I should be directed to a facility, I should be given the time at which the doctor, that facility is available. and then it should ask whether I can book an appointment for you. Once that appointment is booked, you go see a doctor, and then the doctor whom you are visiting, he or she should have your diagnosis, which you have done preliminary on your phone, and he or she will add on or recommend. So idea is that it should be available, accessible digitally, and it should be end to end. It's not like one part of the solution is there, the second part of the solution is not there. Let's say today in the inaugural session, the Deputy CM sir was talking that the the trauma center of a high-end medical college or a tertiary medical college is flooded. Not everybody was supposed to be there, but they came because they don't know where else to go. Because somebody said, "आप यहाँ चले जाओ," तो वो चले गए. किसी ने बोला ये घर के पास है तो वो चले गए. But not everybody was supposed to be there. So optimum utilization of your resources, because it's always going to be limited. So the idea is at the back end, when the problem is starting, we always talk about preventive, proactive, and predictive model. So that proactiveness and preventiveness can start from the beneficiary itself. He or she need not visit a center and then it should start. So first is that part should happen from one end to the digital, to the final end, where even the medicine he or she can buy with a voucher which is generated once the diagnosis is there and he or she is recommended a medicine. He or she receives a voucher and he goes to a pharmacist and he buys that medicine, whether it's a government, whether he or she is through a government program or private program, but it should be end to end. So one thing is that the another part is, rather than collecting data, like now what we do is, let's say there is an HMIS system, we all, and that's a common knowledge that doctors don't have time, and that's a fact also, because we all have visited doctor. There's no time for a doctor to feed the data. He or she will first prefer to write it. So we need to go at the back, like when the doctors in the doctor education or in a medical education, there has to be a course on digitization, because going forward, that's the future. He Like, I am carrying a diary, there is no need, we can all write our notes on the phone, or Devendra is carrying a digital pad. So idea is that it has to be digital. Once that becomes a habit, and that will come through the education. So the data has to be not entered, it should come on its own. So from the data collection, we need to move to data connection, because AI is what? AI is data. And the data is, when it is available without any data loss, it's a quality data which is available. And then AI is there, which has immense potential to build any solution that you desire to have it. And eventually it has to benefit the public, because AI in itself, or the digital solution in itself, is not going to solve any problem till the time we are not able to impact the life of the people.
Adding to this, Jyoti ji, I would come back to you only because we have, I think, 5 minutes more for the panel, and then we'll have 5 minutes to hear out from the audience. So, what do you think? This question is for everybody, but I believe we won't be able to take answers from everybody, seeing the time constraint. What do you think? What could be one key reform that the state should take over the next 3 or 4 years or the next decade to build this future-ready system?
Thank you, ma'am. I think going forward, if I say, because in short term, digitization, short term will not work, but in a medium term, if there is one reform that UP should do, is the HMIS system for all the hospital. And by HMIS system, I don't mean it has to be one single solution. It can be multiple solutions, but yes, as my previous panelists have spoken, there has to be interoperability, because HMIS itself is not going to solve any problem. But what it will solve is, if it is interoperable, the data will be available seamlessly across all the platforms for everybody to see, even for the beneficiary. We always say we have Aadhaar, we have linked the record, we have generated the record. But till the time, if I am not able to see my record and my records are not able to intelligently tell me the nudges which are available in the data, then the data is of no use. So one thing that I think UP should work on is multiple HMIS available and make it a public good. Why we keep it like a, okay, private solutions will always be there, but if a digital public good is created, which can be used even by a single doctor hospital or by a super specialist specialist hospital, that should be one reform that.
Devenji, any 2-3 liner thought on that?
Um, mm, I I think several my own experience. Why UP? I mentioned that UP is a strong leader in the digital health space. One of the reason for that was UP created a architecture and a roadmap few years back, and in spite of multiple changes, UP government of Uttar Pradesh stuck with that roadmap because the speed of digitization will be higher than or speedier than the human imagination. So how do you build the infrastructure and a public good in such a way that the artificial lines of public and the private will be somehow blurred? And that's why everyone is speaking about development of public good. I think the only one point which, ma'am, I will say is for shorter duration, if because there are several problem statements. General approach is I do have a solution, I'm trying to find the problem. If if the if the government decides, okay, I do have a HR gaps, what is the pathway to solve for that? I do have a diagnostic, and I'm just making up here, but I do have this particular challenge, and what is the AI and the digital pathway to solve for this, and not the vice versa? If and second point is, instead of suggesting for a small pilots, of course pilot should be there for some sticky issues, but to the extent possible, if we can operate at scale, because the operating at the scale versus the small pilots are going to be different. Thank you.
Right. So, Dr. Azim, if you
Absolute.
would like to
Yeah,
add, but very briefly in a minute, if you have one final point to make on what UP could do in the next 3-4 years, just a single point. Yeah.
one single point. I understand the problems of financing in government. I've been there. Where to bring the huge amount of money to do it? Very simple thing. Just put all your data into one box and charge a minor subscription fee from anybody. You'll be able to finance thousands of crores of your entire build up as you go forward. We can do that offline, but I'm telling you, the amount of scale that you have, data is fuel for people pay. I can give you more in detail later on, but I'm saying you have everything that you want to do. Let the private sector flower, benefit, but pay for the small amount of the access that they're getting from this. It is doable. It is implementable in the next 2 years' time, finished out without a huge amount of cost, and that will finance your future. You can take that offline. Thank you.
Thank you.
And I completely agree with Dr. Khanna. The think scale, not pilots. Get out of pilots. That's all.
One last point from Vikalpji, if you have anything to add.
I think I totally agree with what Jyoti ji mentioned. HMIS adoption. One of the things that I can definitely say is world has changed quite dramatically. I'm a developer, technologist myself. Like India never see a computer revolution. It just did a step change and went to mobile. You don't need to implement HMISs like Epic and Cerner and all of that. You can straight away go to the voice enabled solutions, clinical data capture, more AI led stuff rather than the whole long build up of an HMIS end to end. So yeah, that could be a big game changer.
So now I would like to throw it open to the audience if they have any suggestion or any their own vision for 2047. Just very briefly, we have just 2-3 minutes. So we would like to hear one or two.
Thank you, madam.
You can come ahead and yeah,
Okay.
just be very brief. That's my request.
Sure, madam.
Yeah.
Madam, I am Deputy STO UP, and regarding AI, I want to highlight that in UP, we already have 28 handheld X-rays which have AI, and we have 765 X-rays in the district. They are digital X-rays, in which 135 X-rays have digital input. The use is what we saw is was in our intercept campaign. 2,000 patients who were asymptomatic, we were able to identify them with the help of these X-rays, because before the diagnosis and this one, the patient might have come later on, but we were
No,
with the
See,
AI.
what is your suggestion on which, how UP can build on for a Viksit
That's right.
data-driven healthcare system by 2047?
Exactly,
If you
madam.
have some suggestion or any comment on what the panelists have said, we would.
No, madam, I fully agree with the panelist. And my concern is that our focus will now be regarding AI in X-ray. We are already doing in others diagnostics. If we can do it, it will be more easy for us to diagnose early. That's my suggestion. Thank you, madam. Thank you.
Yeah, one more, right? Somebody wants to say.
Yeah, I'm Dr. Bilal, Director Integral Hospital, Integral University. Ma'am, I've delved a little deeper into AI, and as pointed out, instead of pad and all, I'm sorry, Dr. Kanayat, you can do it all, transcription and whatever you speak can be done. We are missing out on the Abha platform. Rightly pointed out, there can be multiple HIMSs but talking to Abha. That's one. That's what I think for Viksit Bharat, the government should enforce it. One, strengthen it. Two, and democratize it to the private sector. How do you use it? Hand-holding, supportive supervision, all that. The second question is, the moment the private sector gives the data, it's all in good faith. There's no hand-holding. Then comes the policing. So that's where the private sector is scared of, because they want a lot of hand-holding. There'll be a lot of mistakes, and there the government has to support them. If we have this vision of Viksit Bharat, where the entire data or the universe gets captured, and we have an AI solution to it and solve the problem. That's it, ma'am. Thank you.
Any other suggestion or any other comment? Yeah, this would be the last one. Yeah.
Ma'am, thanks all the panelists for some wonderful points. So I'm Dr. Vishwadeep Goyal. I'm coming from IIT Kanpur. So my suggestion is, while we are talking of data and AI, I think one important thing that we have to do is how do we implement it on the ground? When we heard in the inaugural session that the CHCs, the Arogya Mandirs that are coming up, they are all getting enabled with AI and digital. But the digital literacy, and you talked about it, ma'am, that it is still limited. I think there is a very important need to empower our HR resources, the nurses, the paramedics, in the use of this HIS. Whatever we do, it has to be integrated, it has to be interoperable. The SCM has to be integrated with the clinical solutions. But I think that important part has to be also taken care of. Thank you.
Thank you so much. And I think it's been a very useful and insightful discussion for all of us. With the panelists we had expert opinions and covering government policy, international standards, moving ahead in diagnostics, AI surgery, how we can pool together data, how we can monetize it, how do we need to work on the data security part, spread awareness on the digital initiatives, and work on more PPP models, whether it be in diagnostics or it be in robotic surgery. So thank you everyone for joining, and a special thanks to all our esteemed panelists, including those who have joined online. Yeah, over to Mohit.
थैंक यू मैम। सेशन के अंत में जैसा मैम ने बताया कि बहुत सारा कुछ एक एक्सट्रैक्ट निकला जो शायद हमें विकसित उत्तर प्रदेश बनाने में मदद करेगा। अब हम चेयर, मॉडरेटर, सेक्रेटरी मैम से रिक्वेस्ट करेंगे कि मैम जो हमारा वो है वो ज्योति यादव मैम को सबसे पहले देवेंद्र खंडायत सर को, श्री विकल्प साहनी जी, श्री तन्मय सक्सेना जी, श्री श्रीनिवासा जी। पंकज सर। थैंक यू एवरीवन, धैर्य से सुनने के लिए, इस पूरे परिचर्चा को फ्रूटफुल बनाने के लिए। तो सभी अतिथिगणों को धन्यवाद और सभी पैनलिस्ट को धन्यवाद। थैंक यू वेरी मच। ग्रुप फोटोग्राफ के लिए कृपया जो है मेरे पास। अच्छा, इसके बाद एक दूसरा जो सेकेंड सेशन है वो मेंटल हेल्थ पे है, यहीं पे है। तो श्रोताओं से अनुरोध है कि जो लोग ये मेंटल हेल्थ एंड रिहैबिलिटेशन पे है नेक्स्ट सेशन इसी हॉल में, तो आप सभी से रिक्वेस्ट है कि आप इस सेशन में जो है जो हमारे पैनलिस्ट हैं वो प्रोफेसर अरविंद राज सर हैं, प्रोफेसर पी के दलाल सर हैं, डॉक्टर वी के अग्रवाल साहब हैं एचओडी डिपार्टमेंट ऑफ साइकेट्री, डॉक्टर सुनील पांडे साहब हैं सीएमओ गाजीपुर, और डॉक्टर शशि राय हैं न्यूरो साइकेट्रिस्ट। तो ये बड़ा इंटरेस्टिंग सेशन है। आप लोगों से रिक्वेस्ट है कि जिनका भी थीम एरिया या की एरिया मेंटल हेल्थ से रिलेटेड है, कृपया आप यहाँ रुके रहें। बड़ा इंटरेस्टिंग ये डिस्कशन है, तो कृपया आप लोग यहाँ रुके। धन्यवाद। नेक्स्ट सेशन यहीं पे है, आप लोग कृपया करके रुके। वो पंकज अरोड़ा सर से नेक्स्ट सेशन हम लोग शुरू करने जा रहे हैं 2 मिनट के अंदर। तो रिक्वेस्ट है कि सबसे पहले यहाँ जो हमारे पैनलिस्ट हैं उनका प्लकार्ड लगा दें कृपया, और ये प्लकार्ड जो पहले की टीम है वो हटा ले। देखो कार नेक्स्ट सेशन हमारा मेंटल हेल्थ एंड रिहेबिलिटेशन पे है। पैनलिस्ट आ चुके हैं। नेक्स्ट जो सेशन है वो मेंटल हेल्थ एंड रिहेबिलिटेशन पे है। चेयर कम मॉडरेटर उज्जवल सर को मैं स्टेज पे बुलाना चाहूंगा सर। सर प्लीज आए और इस सेशन का कॉन्टेक्स्ट सेटिंग करें सर।
Kindly settle down, please. A very good afternoon to all of you, distinguished panelists, esteemed colleagues, and partners in progress. Please settle down. I want to have your attention, please. Mental health has emerged as one of the most critical public health priorities in Uttar Pradesh. Over the last few years, the state has taken decisive steps to strengthen this domain, ranging from expansion of district mental health programs, recruitment of psychiatrists and clinical psychologists, deployment of telemanas helplines, and integration of mental health services within NCD clinics and district hospitals. The establishment of new medical college with psychiatry departments, improved psychotropic drug availability through UPMSCL, and community-based outreach initiatives in several districts have all contributed to better access and early intervention. Uttar Pradesh has also expanded de-addiction services, school mental health programs, and partnership with agencies like NIMHANS for capacity building and training of primary care teams. Mental health is often called the silent epidemic, and addressing it requires a multi-pronged approach. As the state aspires for Viksit Uttar Pradesh at 2047, mental health must transition from a peripheral agenda to a core pillar of human capital development. The path ahead demands a structured, multi-tiered response, scaling up district mental health program to all the districts, developing modern mental health and rehabilitation centers, strengthening psychiatry and clinical psychology training capacity, integrating counseling and psychosocial support across schools, colleges, workplaces, communities, and in community settings, and investing in digital mental health platforms for screening, follow-up, and teleconsultation. Today's meeting brings together leading psychiatrists, clinicians, administrators, and technical experts who will share practical insights from clinical practice, district level implementation, academic institutions, and digital public health, and will collectively explore how Uttar Pradesh can build a robust, scalable, and inclusive mental health ecosystem. As we deliberate today, the focus is to outline clear, actionable recommendations that can help Uttar Pradesh become a national leader in accessible, high quality, and community-driven mental health care by 2047. I welcome you all once again to this very insightful session, very challenging and very demanding session on mental health and rehabilitation. Now I welcome all my panelists to the stage. First of all, okay, please.
Thank you so much, sir, for setting the tone to the session. Ladies and gentlemen, we are honored to have a lot of eminent experts here amongst us and whose insights will actually, help shape the roadmap for the state of UP. I'll invite the session panelists to kindly come to the dais, starting with Dr. Arvind Raj, additional professor at NIMHANS Bangalore with deep expertise in mental health systems and telepsychiatry model. Welcome, sir. Please take your seat. I request the team to present a bouquet of plant to Dr. Arvind Raj, please. Please. Glad to have you, sir, all the way from Bangalore to this session. Thank you. We would like to invite Professor P.K. Dalal to come on the dais, a leading psychiatrist from Lucknow, known for his work in community mental health and rehabilitation programs. Welcome, sir. I'll request Dr. Vivek Agarwal to please come to the podium, Head of Psychiatry at KGMU Lucknow, specializing in clinical psychiatry and mental health education. We also have with us, and I'll invite Dr. Sunil Pandey, Chief Medical Officer from Ghazipur, who's got hands-on experience in integrating mental health services into public health system. Thank you so much, sir. And we'll also invite Dr. Shashi Rai, Senior Psychiatrist and Advocate for Mental Health Awareness and Patient-Centric Care. Welcome, ma'am. With this, I now hand over the mic to the panel session chair to take the session forward. So,
Hello. Question to the Dr. Arvind Raj, first of all. As UP strengthens a statewide integrated mental health delivery system, from your NIMHANS experience, how should the state build on the core system elements like governance, digital tools, workforce models, or service pathways to bridge the mental health access gap as we move towards 2030?
Good afternoon, all. First of all, thanks for the opportunity to discuss about mental health in a larger health system, because that itself is a welcoming move. The reason is that there is no health without mental health, and actually mental health is everyone's business. Unfortunately, sometimes it doesn't go that way. So I really appreciate the department and the ministry for bringing in this particular session as part of the overall program. Now, getting back to the question on the governance part and then the tools related to workforce, when it comes to the services, most of the time it is focused on the curative aspects of mental disorders. But we all know, unlike other disorders, the causes are bio, psycho, and social in nature. So it is always very important, that too from a public health point of view, to focus on promotive and preventive aspects. And in fact, the scope of mental health services, the scope of mental health services is much more higher when we talk about promotive, preventive, and curative. And of course, the cost involved in curative aspects can be much, much lesser when we focus on preventive and promotive aspects. That is something which is missing, not just in this particular state overall, because the focus is always on the curative aspects, curative and rehabilitation aspects. And then when it comes to the curative aspects, it's more focused towards hospital based and then somewhere center related things, whereas it has to be decentralized as part of community based services. As we all know, the kind of stigma attached with mental disorders as well as treatment of mental disorders, it's just not with the so-called illiterate persons. We all know, since we are in health field, we all know even bureaucrats, even other people from other departments, they would just not be able to accept somebody has mental illness in their own family. And obviously it will be more among people who are illiterates and those who are from the rural background. So to break that, we need to be out of those four walls, and then we need to make sure how much ever possible we need to make it more as a community based services. When I talk about community based services, even at the curative level, obviously preventive and promotive will be community based. So that to some extent will bring down the stigma, and then we can make the services more accessible. And one level integrating it with the general hospitals, and then the next level integrating it to the community based services. And when we talk about the stakeholders who are involved, even in terms of providing services, we should not just restrict within the health discipline. Even within the health discipline, there should be a lot of multidisciplinary approach. As I already told you, the causes are biopsychosocial in nature, at least as per the act, that is Mental Health Care Act or mental health policy. We need to make sure all the mental health professionals at different levels are part of the services. This is within the discipline of health. And we also should not forget about the intersectoral approach to the level of involving community level workers. For example, we are training the lay persons under the name of well-being volunteers. The last 10 years, we are training somewhere around 500 to 600 well-being volunteers, and they have referred thousands of persons with mental illness. Just not referring persons with mental illness, but also they conduct a lot of programs in their own capacity, in their own place where they are working, in their apartments. And that's how we can actually normalize about talking about mental health. So the point here is how we can involve other stakeholders, to some extent, even these traditional healers. Why should we ignore them? Because we all know they use better psychotherapy techniques like mental health professionals to some extent in terms of active listening and helping people to ventilate. So why don't we bring them as well? They are the most influential people in the community. So that way, how much we can include, different stakeholders. Of course, when it comes to the digital tools per se, probably like we all are aware of the Telemanus. And also Telemanus is more of service oriented. Also in terms of capacity building, like we also have something called as Niman's Eco model, where there are small self-learning modules from the government, from the state government. Can we, with the Center for Excellence like King George Institute, can we initiate such self-learning model? Let's not duplicate whatever is there at the central level, but which is applicable to the state. That way can we do that? And when it comes to workforce, we need to talk about, as I told you, different stakeholders. Let's just not restrict ourselves with health professionals, that is mental health professionals. Of course, we know the number of mental health professionals, the proportion is much, much lesser. We need to increase this definitely, but also to the level of ASHA workers, to the level of volunteers, can we build their capacity at different levels? When I talk about volunteers, can we build their capacity in just referring persons with mental health? At the district level and at the tertiary level, can we train them in terms of treating the persons with mental health? So that way, different workforce has to be trained at different levels, which has to be taken care. Yeah. Sorry for taking more time. Sorry.
As you rightly said, that there is no health without mental health. We all should aspire for a better mental health for all, and how affordable and accessible mental health services can be provided to the populace of UP, which is the discussion point. Now I move to Professor PK Dalal. The question to you, sir, is for a state as large as UP, which rehabilitation models, daycare rehab centers, halfway homes, community rehab, peer support groups, and supervised digital follow-up are most suitable for district level scaling? Adding to it, de-addiction centers, how can we run it? How affordable and accessible it can be made?
Thank you, sir, for having me over here. And I welcome all of you for this session, because seldom we see that in health, psychiatry is being included. And but after COVID, I mean, before COVID, we used to say a lot of things about promotion of psychiatry, but nobody listened to us. But when COVID happened, and then when a havoc started, that how people are feeling, how mentally miserable they are, how much of anxiety, depression, and other problems they cropped up. So then people have started appreciating about mental health, and then they started indulging more into it. And after that, the budget also increased for mental health. And then when it was seen that how much trained power do we have, and we found that it is almost negligible. I mean, we are having around 10-12,000 of psychiatrists in India, and less number of trained psychiatric nurses or trained psychiatric social workers, right? So one is about the scaling of manpower, because psychiatrists cannot do all these things, as professor from NIMHANS has said, that it is an integrated service delivery system. So one has to have these trained I would say, psychiatric professionals. And for them, the first and most important thing I would request Mr. Ujjwal to please recommend from this forum that at least psychiatry should be made an undergraduate subject. We are fighting with NMC, with MCI for years together, and nothing has yielded. I mean, the Dr. Saab, he's training say the medical officers only because they do not know anything about psychiatry. Why? Because they are not taught psychiatry during their UG days, undergraduate days. So if it will become, we are just claiming that it should become at least a minor subject, and to be examined by psychiatrists only, not by the medicine people. Nowadays, what is happening is that undergraduate, I mean, there are certain courses and which are being examined by medical specialists like MD medicine people. And so the undergraduate students, they do not pay any attention to that, because hardly a short note comes of 5 marks or 10 marks, and they say that we will get over it by writing, by scribbling any damn thing. So an undergraduate subject is very, very important, and by that the students will be exposed to psychiatry, and then probably his job will also be easier. When they will go to community, they are already trained, they are already knowledgeable about psychiatry, and then they can be, it will be easier to handle them, because then they will see the importance, what is the importance of psychiatry. As he has said, that stigma is playing a very, very big role in medical profession as well. We know people who are, I mean, husband, wife, both of them are medical people, but they do not want their children to go to psychiatry. So that is the stigma which is still there in medical fraternity, what to talk of a common person. And similarly, the other areas like trained nurses, trained psychiatric social workers, all these things, the institutions are very important. As regards to UP, you see, I would say that all the medical colleges, government or private, should have an independent department of psychiatry. We are keeping one psychiatrist actually, as far as NMC criterias are concerned. That is, medicine department has one, they require for UG course only one psychiatrist. So he will see the OPD and all these kind of things. Beyond that, nothing happens. So if there is a PG department of psychiatry, then it will be a full-fledged department of psychiatry, and they will be training not only graduate students, but also they can have, we can build up in giving training to the psychiatric nursing, psychiatric social workers, and others also. What the Center of Excellences are doing, actually, then every medical college will start doing that. So this will tremendously build up the capacity. So that will be another thing. The third thing is about mental hospitals. You know, Agra is, I have visited with the then Principal Secretary, Mr. Arvind, to all the mental hospitals of Agra, Bareilly, and Banaras. And they are having tremendous scope. And Agra, because of the Supreme Court order, has now become a center of excellence, and it has started training not only the medical graduates, but also for that. So in that model should be applied to both these mental hospitals also, because they are having tremendous patient input, they are having tremendous land, and if they can be developed as a center of excellence, a lot of work can be generated, and a lot of training of manpower can happen. Because you see, all the other which sir has said about that, establishing of de-addiction centers and doing all these things, it centers around psychiatrists, because we are trained in doing that. But with that, all the other paraphernalia is also essential, because as he has said, biopsychosocial model, so we require a lot of other manpowers, and then integration with NGOs. That is also another a very important aspect that we should try to incorporate all of them. So all these things are very important, and I would suggest sir to take at least our what I would say, this is our pain, that we see a lot many countries, like say Sri Lanka has psychiatry as a undergraduate subject, but we, as big as nation, we fail to do that. Plus, as I have said, PG independent PG departments, and all the departments, all these PG departments should be given facilities for training manpower. We actually lack in trained manpower setup. So with that, gradually we can fan out, and we can plan all these things of halfway homes and de-addiction centers and all these things. So trained manpower is the requirement of our state. Thank you.
Thank you, Professor P.K. Dalalji. As you rightly said, that the importance of psychiatry or mental health has emerged just after COVID, and we need to have more and more of experts, more of stakeholders consultation, and more such institution, and we need to bring the subject psychiatry in UG courses. And now moving on to Dr. Vivek Agrawal, who is head HOD of KGMU Psychiatry Department. From you, I would like to know, UP aims to significantly expand its mental health workforce by 2030. What reforms in psychiatry and psychological training, internships, digital competency, and supervised practice must be prioritized? Over to you, please.
Thank you, sir. A very good afternoon to all of you. As already emphasized by Professor Dalal, that our services are lacking largely due to lack of manpower that is in mental health. If we go by the data, then we hardly have 0.5 to 0.75 psychiatrists per 1 lakh population, which is grossly inadequate. And other mental health professionals are even less. So large number of mental health manpower is required. So government has taken steps to increase the manpower development in this area, as Center of Excellences have been established under the manpower development scheme. But still that is grossly inadequate, seeing the number of population we have. The treatment gap, if we look at, is almost 80 to 90% in psychiatry. So huge gap is there. So how do we go about it? So one is that the government has pushed for the increasing the number of seats in the MD psychiatry, increasing the capacity in psychiatric social work, MPhil in clinical psychology. But what the problem is that the quality of professional being trained has come down. So the standards are not being maintained. We see large number of clinical psychologists are being trained theoretically. They do not have, or they have very minimal exposure to the patients. So in the just to increase the manpower, the quality should not go down, because that is again similar to the not providing the proper care by the less or trained manpower. So standardization of teaching is very, very important, and that should happen across the state. So we at KGMU are eager to help. We can handhold, we can do the training sessions, and we can look for the quality management, but that is very, very important. Also, there should be more use of technology in the training, availability and the training in the telepsychiatry modules, safety of data, comfortable compatibility with the telepsychiatry. All these things are required, because in the times to come, all these things will become more and more reality. And in coming times, one should also get acquainted with the use of AI. Although it is very controversial at present, but it is going to come in a big way. Patients are already using AI in diagnosing them, seeking therapeutic help. So digital psychiatry is going to come in a big way, and it's a good medium for reaching the large number of population with less number of people. So there will be mental health apps, there are apps developed for therapies like digital cognitive behavior therapy. So people can access that and they can take help from these kind of things. But there should be standardized apps which have been validated. Otherwise, they can also harm the patient. So these kind of changes are required in the training of the manpower. Thank you.
Thank you, Dr. Vivek Agrawal. As you rightly said that there is lack of manpower. The number is very depressing actually. 0.5 to 0.75 psychiatrists available for 1 lakh of population. And you suggested that quality of training need to be improved. We need to use AI and digital technologies to increase our outreach. Now moving on to Dr. Sunil Pandey, I would like to ask you, I would like your opinion on the subjects like how can mental health services be integrated into primary healthcare delivery at district level?
मंच पर आसीन परमादरणीय हमारे सीनियर्स और सभागार में उपस्थित हमारे सभी सीनियर्स कलीग, हमारे साथी, बीइंग ए मेंटल हेल्थ प्रोफेशनल, सर मैं आपको बताना चाहूँगा कि आई एम with this for last 20 years, more than 20 years. I am working with mental health, making policies from state to district level. In 2004, sir, I'm honored to have the presence of my teacher, my guardian, Professor Dalal with me right now. I'm sharing the stage with him. He is the, and my on left side, my senior ma'am, Dr. Sashi Rai. She was pool officer. My colleague, Professor Vivek Agrawal, my colleague, Dr. Arvind Raj from NIMHANS. He was my trainer for psychological management of disaster. During disaster, how to. He is a very good orator. Right now, he has no time. So, lot of time, if you say to speak out, I will continue. I can continually speak for 3-4 hours continuously on this topic, particularly because I had many sessions from the policy making from Nirman Bhavan, Delhi. Right now, I'm serving at the very grassroots level as a CMO in a district like Gazipur. The bitter truth, the type of border of the Bihar, where you don't have even a PSC that is converted into the Khandha. We have Ayushman Arog Mandirs. So, first of all, we will not go to the negative aspect of the life. The purpose of this symposium and to invite me particularly, I think, to 2047, the Viksit Bharat, whether it will be pleasure for us or whether it will be stress for us. Right now, we all are facing the stress. The way or the other, either one family member or the other family member is having some or the other stress, either of the age group from the young generation to the geriatric age group. We have lot of plans. We are planning very properly, but it's very difficult to perlocate these to the grassroots level. The problems are the same. The lack of manpower, the trained staffs, Professor Dalal sir already told. During COVID time, these facilities will be provided by the concept of Telemanas, the project of NIMHANS. This project was appreciated by Government of India. Still, they are running in our 4 centers: Gorakhpur, Varanasi, Agra, Bareilly. So we are working on it. But the thing is this, whether we are able to perlocate these number, that is tele helpline number 14416. I don't think everybody knows this Telemanas number. When we people sitting in this, we are all educated, literate, then how can we expect anybody living in rural area asking for even bread and butter? They're unable to earn bread and butter. They are in stress. Second thing, I think so, it's a behavioral aspect. Usually patients come to us as a mental professor, they want to they don't want to display their emotions on phone. This is the practical problem. They just want to conceal their emotions, and they just want a man who can empathize with them. So Telemanas number, in spite of our great effort, the number of the calls on the Telemanas are not increasing. Our state mental health cell, our district mental health cells are working very hard. Right now, the government of India sanctioned 300 community psychologists or the counselor post, but unfortunately it could not be filled. And we hope that with the guidance of sir, these will be filled very soon. As we know, we have 75 districts, but we have only qualified psychiatrists in less than 45 districts. The appointment was done initially by Professor Dalal and at KGMU, then from Directorate. The training was done by Professor Dalal, Professor Vivek Agrawal. They trained our 1100 PMS doctors, and they are running at least OPD on one particular day, that is on Thursday at CSC level. And this needs more effort. The purpose of this particularly OPD at particular day, the Man Chetna Divas, we called it Man Chetna Divas. The purpose was that we should try to identify the basic common mental illnesses at the grassroots level. And the doctors, we invested a lot of on them by teaching them at KGMU, at Mental Hospital Agra, Varanasi, Bareilly, even GSM Medical College, Department of Psychiatry. Lot of effort was done. It was in-house training of 1 month, complete 1 month. They were trained enough to diagnose the common mental illnesses as well as to treat them from the basic drugs. If they need hand holding, their seniors are always there, qualified professors, psychiatrists are always there to help them. But are they really working on ground? This is the question, big question. The people are interested, the doctor particularly, I am talking about the PMS doctors who is working at PSC or CSC level. Those doctors who have some problem in their family, they are interested to learn about psychiatry. They are practicing psychiatry. So it's a good achievement for that purpose. But up to 2047, I won't be there, I think so. I am around 60. So I don't be there. But we are planning for that. So definitely, Professor Vivek Agrawal Saab told us about many apps. One thing more, I have given a lot of topics like mobile mental health units. Of course, they are very useful. One of our famous psychiatrists in Varanasi, Dr. Jhamar, he told us, he suggested many times in State Mental Health Authority Baithak, particularly meeting, कि this should be launched because everybody cannot reach to district hospital level, or because districts are very wide. When we talk about Prayagraj, Gazipur, the distance from the one block to the main center is up to 45 kilometers. To bring that particular patient from periphery to the main headquarters is difficult. Fortunately, I worked for about 1 year, for last 1 month, 1 year in Varanasi Mental Hospital. I said it a very pity situation. The conditions of the jail is better than the mental hospitals. Now government is focusing on mental health issues. This is very good. At least we are here, at least we are discussing. I am fortunate enough to see, previously we were just making policies, and as a nodal for state nodal mental health, We just order to CMOs, do this, give the report, and how many patients you have seen in OPD, how many indoor patients, what is the number of drug addiction, even tobacco control. I was looking after tobacco control program also. What is the yellow campaign? How many students? Even I was looking school going program. So lot of things we are planning at state level, but at the grassroots level, these should be perlocated. This should reflect. So it's my humble request that everyone who is present over here, they should be sensitized enough. Although people are getting sensitized, and we have to request the government, please employ more counselors. Not if you are unable to get MPhil in clinical psychologist, at least uh, we can have counselors, psychologists, we can train them. We have lot of master social MSWs. We can give them basic trainings because at grassroots level, nobody wants to go. And we have lot of pressures because of digitalization. Every report, simple report, 90% of the time of the doctors is busy in fulfilling the report, filling the report at the various type of portals, whether it's a Nisha portal, whether it is and lot of portals are there. HIMS portal for vaccination, UWIN, EWIN, lot of portals are there. So there's no problem of money, but the problem of manpower is there. The schemes are already there. If we follow the scheme, we will achieve everything. But we are not able to achieve them. Now the important question about the drug addiction center and rehab centers. The integration between social welfare department, health department, Bal and Mahila Kalyan department, and even Madhya Nishad department is a part of social welfare department. The integration, lack of integration is there. Government of India is continuously opening addiction treatment clinic, ATF clinics. We are working on that. Fortunately, AIMS is a nodal, but it is controlled by social welfare department. In a district hospital, when there is a district mental health program unit, we are not fortifying it. We are not putting effort to integrate drug addiction facility in that. That have psychiatrists, that have clinical psychologists, psychiatric social worker, monitoring evaluation officer, psychiatric nurse, community nurse, CRA, ward assistant. They have everything. But we are opening a separate unit, ATF, just a side of DMHP unit.
Thank you, Dr. Shuni.
Sorry, sir. I have taken a lot of time.
No, not a problem. Now,
please, thank you so much.
fine. We'll moving on to Dr. Shashi Rai. Would like to know from you that stigma still prevents families from seeking help for mental health concern or rehab needs. What statewide communications and awareness approaches can normalize help-seeking behavior?
Good afternoon and good day to everyone. It's a privilege to be here, and I'm thankful to the organizers for having given me this opportunity. I start from where Dr. Dalal and Professor from Nimhan started, no health without mental health. And when we say this slogan, that no health without mental health, then how do we start our health teaching of MBBS without psychiatry? So that should be definitely a subject of undergraduates. Now coming to the point of rehabilitation and stigma reduction. See, we already have spoken that the treatment gap is summed to the power of 70 to 80%. And when we come to rehabilitation, it is, you can say, as icing on the top because hardly people are aware that there is something like rehabilitation. Like we are running a rehabilitation center in Lucknow itself for the last 20 years. There should be at least 5 to 6 rehabilitation centers for whole of UP. But there is none as such because rehabilitation is something which is very important. People feel that a person is psychotic, a person has depression, he has schizophrenia, and you give medication and that is the end of it. But that is not the end of it at all. One has to be reintegrated into the society. The person has to, गाड़ी पटरी से उतर जाती है, उसको दोबारा पटरी पे लाना होता है. Only then that person can function properly. So basically rehabilitation is you bring out the best optimal functioning of the person with whatever is left. अगर उसे कोई बीमारी है उसका इलाज करिए, पर बीमारी के सिम्टम्स कम हो जाते हैं, but in spite of that the person can do many things. He can do his job, and it is at different levels. So rehabilitation in that point of view is very important, and in that the most important is psychoeducation and community awareness, because many a times a person is treated, he gets well, he goes. I'll give you a concrete example that a person who was properly treated, he was admitted for 3 months, then became well, and he had a shop. When he went and opened the shutter of his business, the neighborhood shopkeeper said, "Are pagla fir aa gaya." And that person, he put down his shutter and he came back home. So this is the level of stigma which we have in our country. And how can we remove this? Right from school levels, in school mental health programs, like we have ENT checkup, we have eye checkup. So similarly, something minor like a psychological checkup, if it is integrated into the school mental health, it will go a long way. I have number of children like who are having mental illness, and when they are treated, and for the betterment of the child, sometimes I've told the parents, okay, you can tell the teacher that he or she is not well. So, but sometimes it, backfires. The teacher says, the students come to know that this person is not well, and nobody gives him the copy. कि homework उतारने के लिए कोई इसको copy नहीं दे रहा, कोई help नहीं कर रहा है. Children don't shun him. To the our rehabilitation center where we have a boy who was very brilliant in studies, a BSc student. When we celebrated his birthday, he said, "Auntie, thank you that we called us here to this rehabilitation center, because मेरा तो कोई दोस्त ही नहीं है. People do not make friendship with people who are having mental illness." So that is very important कि school से हम शुरू करें. हर school में counselors, वैसे आजकल that trend is improved. Generally, schools do have counselors, so that should be fortified, and normal some psychological checkup should be done. Similarly, in every workplace, like I'd been invited to an IT workshop where the people, I mean, there is so much of anxiety, but nobody wants to share because they feel that things, if people come to know, my promotion will stop. I will not be able to get the job, or maybe on some pretext, I will lose my job. So for stigma reduction, it's very important psychoeducation, community awareness, that, and there should be frequent, and especially people who have done well in life, in spite of having mental illness, if they speak, that makes more sense to the patient. Like suppose we go on speaking, it does not strike a chord. पर अगर कोई व्यक्ति है जिसको बचपन से 17-18 साल की उम्र से बीमारी हो गई, मानसिक बीमारी, वो IAS बन जाता है, IRS बन जाता है, and then that person speaks, it makes so much of difference to the patient. So that is very important कि हम उन लोगों को बुलाएं जिन लोगों ने मानसिक बीमारी को जूझते हुए भी एक किसी मुकाम पे पहुंचे हैं. There are simple things. In what do we do in rehabilitation? मरीज है, वो दवाई खा रहा है, सो रहा है, उसका वजन पुट, घर के बाकी लोग सब स्कूल जा रहे हैं, कॉलेज जा रहे हैं, वो बच्चा बेचारा घर पे पड़ा है. So when we have these halfway homes, जिसकी हम अभी बात कर रहे थे, डे केयर सेंटर, halfway home, we usually call these people from 10 to 4. So when they come, there are simple things like किसी को नमस्कार करना, eye contact, social smile, ये छोटी छोटी चीजें भी ये लोग भूल जाते हैं, नहीं कर पाते हैं. So skills of daily living, then vocational training, and then we should try to put them back कि अगर वो कोई काम कर सकते हैं, because work is the best healer. जितना अगर व्यक्ति काम करे, that is very important. And मतलब कि that question was for rehabilitation to be more effective. A proper planned follow-up is very important. कि जब हम किसी को discharge करते हैं, तो हमें clear cut उसको बताना है कि you should come after so many days. There should be a crisis plan. If you suppose in spite of the medication, you fall ill, you have certain symptoms, what should you do? So that they can fall back then, because then they realize, okay, yes, the doctor has more interest in my well-being and he's concerned about. So I think this is all, but as far as the, and one thing I would like to add, which is a little away from this, regarding the Mental Health Act. Like in our country, the family, the community is the most important person who takes care of the patients. पर हमारा जो ये नया मेंटल हेल्थ एक्ट बना है, उसमें फैमिली को इम्पोर्टेंस को हटा के द नॉमिनेटेड रिप्रेजेंटेटिव्स हैव गिवन. सो आई थिंक 2047 तक अगर कुछ इस पे काम हो सके, the family is again given the same importance, because we are not Western countries where the patient is left alone. The patient is taken care 99% of the cases by the family. और यहाँ पे हम nominated representative just because of cut and paste west से ला के कर दें, that is not good. That is not good for our country. So I think these are few things which I would like to enumerate, unless you want to ask me something else.
Thank you, Dr. Shashi. Just a quick question from Dr. Arvind. Many states struggle with monitoring outcomes, as Dr. Sunil Pandey was saying, that programs are there, but monitoring is not happening, and the district level intervention is not happening. Percolation at grassroots level is not happening. So, what state level measurement and quality assurance form framework should UP adopt to track progress in mental health services and rehabilitation over the next 5 to 10 years?
Okay, yeah. Let me just take an example just to talk about this lack of monitoring. Even Sunil sir was talking about the number. I'm sure how many of you were aware of 14416 even before this program came? All right, maybe probably 4 out of 60. And now, how many of you have either Zomato app or Swiggy app or Flipkart app or whatever, Amazon app? How many of you have either one of this? Either one of this. Many of you, isn't it? Now, how many of you have Telemanus app? Only that kid is raising her hand. I think that's for some other reason. Yeah. 1 out of 60. And we are all from health department. You know, like when he's asking about monitoring, right? Like, first of all, about self-monitoring. But of course, when it comes to administration, it doesn't just stop at self-monitoring. So what I would like to suggest is that, of course, as the name monitoring says, it has to be periodic. It's just not that I'm starting a project. And that's how even DMHP failed in the initial days. In 1980s, when they started DMHP, and yes, of course, NIMANS was the nodal center, and then they started off, did not pick up at all. As a project mode, when something happens, it will be all great. How are we converting that into a program mode for which we need to prepare the stuff even before starting a program? Starting in not just in terms of the outcome indicators, because generally we discuss about what are the outcome indicators. For that, what are the required structures and what is the required process? Structures, physical structure, workforce, and then how is that being implemented by that particular workforce? And just even before starting the program, let's have a baseline data of all these things. In terms of structure, like, you know, how many, for example, now there are, as Sunil sir was saying, there are only 4 Telemanus cells, if I'm not wrong. There's one mentoring institute, that is King George Institute. And that would be the baseline. And then can the government, state government, come forward to join hands with the central government to just increase the funds, to increase the number of these mentoring institutes or even Telemanus cells? And throughout that, are we monitoring the number of, you were saying the numbers are less. And that is actually because of lack of awareness. No one knows, like, I should call now, you know, incidentally, what is the day today? World AIDS Day. Every one of us know. World Mental Health Day, not many of us know. And there used to be advertisements even for NMHP. Like people, there was an advertisement where 2 women will be walking and then they will be talking in a very different way about dental health. You know, the next house guy has got a dental problem, and we will be wondering why they are talking so much of, secretive about dental health problem. Then there will be a question on the monitor saying that, do you really talk like this about dental health problem? Then why do you talk like this for a mental health problem? You know, some of these innovative, of course, we need to have publicity for any health, but definitely for mental health. Unless we do that, and when we do this is the process I am talking about. And when we do these kind of processes, let us see the indicators which are coming up periodically. After creating this awareness, is their number of calls increasing? And that has to be done periodically, and definitely we will not be 100%. And we need to find out what are all the gaps. and we need to be open enough to accept the gaps. And please involve all the stakeholders when we are considering the monitoring and evaluation, just not within the closed door or something like that. Sir was talking about NGOs, and they have enough resource. Only the technical aspects they don't know. And sometimes they even have funds because they are also getting funds from different departments. Let us involve them. They can be part of that, and different other stakeholders. And together, the monitoring system, once when it is periodic, definitely we will be able to get these indicators right. And let those assessment schedules be in line with National Mental Health Survey, where they are also addressing the system-based assessments. If that is in line, we can always merge our data with the national data. That's my view about that. Thank you.
Thank you, Dr. Arvind, and thank you all the panelists. Any quick question from the floor, please, or suggestion?
Any questions from the participants here that you would like to speak to the August panelists here? So request to please introduce yourself and then ask the questions, please.
Yeah. Good afternoon, everyone. I'm Dr. Amit Singh from UPMS SAFI. In sync with what ma'am has told just now, Dr. Rai, regarding an upcoming health problem, autism, ASD, of epidemic proportion sort of. So not much is being done about that. I'm talking in particular about the support system. So we lack even a basic support system in India for such children and their parents. In terms of support, all we have is a rebate of 75,000 to 1.25 thousand, 1.25 lakhs per year, old tax scheme, Section 80DD. Other than that, even that has been done away with in the new tax regime. So these patients, children, and those with other neurodevelopment disorders, they have a long way to go in the society. We lack the basic infrastructure in terms of autism care, acute schools, civil schools, and all. So all the patients in Uttar Pradesh, they are being running to Lucknow to a few private concentrated centers, and that's a big lacuna we are creating that has to be dealt with as soon as possible. At the policy level, the way we have at UK, USA, support system, long life. तभी जैसे मैडम ने कहा कि इनको आगे बढ़ना तभी बढ़ेंगे अगर सपोर्ट मिलेगा. Thank you.
Any other question?
Good afternoon, everyone. Myself, Dr. Neetu Shukla. I am DGM NCD at NHM, and I am also looking National Mental Health Program and Telemanas Cell as well. I thank Dr. Sunil Pandey sir for raising such genuine questions and including the questioning for regarding the low awareness about Telemanas number. I would just like to clarify one thing is that the program was started in 2022 and 2023 Uttar Pradesh got award as the third state with the largest number of calls that we were doing, and since then we have been improving a lot. On a daily average we are receiving, can anybody guess how many calls we must have been receiving? Can anyone guess? We are receiving nearly thousands calls per day and even more than thousands calls. During Swasth Nari Sashakt Abhiyan, we have even crossed 1500s. And on 10th of November, or exactly on 10th of September 2025, we have crossed 5 lakhs calls from Uttar Pradesh itself, and it's a great achievement for us because during Sashakt Nari Abhiyan, the women's which were, we all know that they don't come up for themselves, they never talk about themselves, and they will also physically never come themselves. The calls increased more than 50% during Abhiyan. That was the great achievement for the Telemanas cell and the Telemanas numbers. On the whole Telemanas cell, we have nearly 64 counselors and they are working round the clock. And we are very much grateful, thankful to them because as sir has saying, the sir has also been seeing the National Mental Health Program through school health program, which is also being done to DMHP.
So I believe the feedback is on the positive note for the telemanus thing.
But
Fair enough.
audience over here may not be aware of it, but we are in the process that we are sharing this number with other departments, including child health, education, disabilities, and each and every
Fair enough.
department.
Probably one last word, yes. One last word on this, and then we can probably take it forward.
Sir, can I just
Like to speak some?
just for two lines? This is regarding the autism. I really wish that by 2047 we have certain centers for autism, because that is a real burning problem. The private centers where there, it is not affordable to patients, 8,000, 10,000 per month, and there is none in the government sector for proper training and education. So such schools should be there, and there should be integrative teaching for them.
Fair enough. Thank you so much, ma'am. Thank you so much, sir. I think with this, we've come to the conclusion of this session. I would now request Dr. Ujwal, sir, to kindly hand over the memento to the panelists one by one as a token of gratitude. Yeah. I request, sir, to please hand over the memento to Dr. Arvind Zad, sir, please. For Professor P.K. Dalal, sir. Dr. Sunil Pandey, CMO Ghazipur. Dr. Vivek Agarwal, Head of Psychiatry, KJMU. And Dr. Shashi Rai, the neuropsychiatrist here. As a token of gratitude, I would also request to hand over a memento to Dr. Ujwal, sir, please. Thank you so much. I think with this, we've come to the conclusion of this session. All the participants are requested to proceed for lunch. It's there on the ground floor. Thank you.
Namaskar. I am honored
Hello, hello. Good afternoon, everybody. It's my pleasure to welcome all of you in the afternoon session on creating new centers of excellence in health and public health. I would first like to welcome my Srimati Arika Akhori, ma'am, Special Secretary, Department of Medical and Health, Family Welfare, to chair and start the session, ma'am. We are honored to have a very distinguished panel with us today. Our first panelist is Dr. Manish Chaturvedi, professor at the National Institute of Health and Family Welfare, New Delhi. He has more than 20 years of experience in research, teaching, and leadership, and has worked closely with WHO, ICMR, and the Ministry of Health. He is widely known for his expertise in public health policy and health strengthening system. Our second panelist is Dr. Arvind Mohan, Professor of Economics and Dean at the University of Lucknow, and Adjunct Professor of IIM Lucknow. With deep experience in economic policy and development, he has worked with the World Bank, UNDP, UNICEF, and USAID. He has contributed to major state level policies and is a respected academician. Our next panelist, Dr. Harsh Sharma, is health economist and director of Giri Institute of Development Studies. With over 27 years of experience across academia and government, he has played a key role in many capacity building programs and development initiatives for Uttar Pradesh. We are also privileged to have Dr. Sumita Ghosh, Senior Fellow at Niti Aayog and former Additional Commissioner for Child Health at the Ministry of Health. With over 4 decades of service as a pediatrician and national program leader, she has shaped major child and maternal health initiatives and contributed into the important national policies. Our final panelist is Dr. C.M. Singh, Director of Dr. Ramano Lohia Institute of Medical Sciences, Lucknow. With 24 years of academic and administrative experience, he has successfully led a major hospital expansion and has been recognized with several prestigious awards for excellence. With that, I warmly welcome all the esteemed panelists, and please join me with a round of applause for all the panelists. Thank you, ma'am.
Thank you, Dr. Shipra. Let me introduce myself. I'm Arika, IS officer of 2013 batch, and I'm posted as Special Secretary in the Department of Medical and Health and Family Welfare. On behalf of the department, I wish to extend my warm welcome to my panelists. And as all of you must be knowing, my session is on creating new centers of excellence in public health and overall in the health sector. As we move towards Viksit Bharat 2047 and UP being the largest state in terms of population, we also chart our own path towards Viksit Uttar Pradesh in 2047. So when we look at the institutions of excellence, we look at centers which drive innovation, which do research and give us the data on which evidence-based policy making can happen. And these are the anchor points for collaboration between government, academia, and industry. So moving ahead in 2047, when we look at 2047, over the past years, no matter how much advancements we have made in the medical field, we still, if we sit down to list our centers of excellence in India and in Uttar Pradesh, there are only a few handful, which are islands supposed to be serving 140 crore of population. Institutes of excellence like the AIIMS, PGIs, JIPMER, NIPER, CDRI, if we go on listing them, they're few and far between, and we wish to have more such centers of excellence, institutes of excellence. But how to do it, how to identify the areas where we need to do them, how do we go about the the legislation, the support, the funding, the other logistical help that these institutions would require from the government, and what thoughts do we have on these are the discussion points for this session. Um, I think, sir and ma'am, sirs and ma'am, as we move ahead, I think the first issue would be to identify the verticals on which we would want our centers of excellence to be built around. These are my thoughts, and I think I would like to hear each one of you in brief um, on what are your thoughts on this topic of how do we go about creating these institutions, um, which areas should we address, and what are your thoughts in general, because you all of you are heading uh, big institutions, you're working in them, so you will be best placed to shape our vision. So we'll start with Dr. Harsh Sharma, if you may share your thoughts.
Thank you, Ms. Akhori. My co-panelists and members of audience. First, let me clarify, since there are many doctors here, actual doctors, that I am not really a medical doctor. I am only a PhD holder, which is just gives us this kind of. I think many medical doctors, I know many friends who don't like that word to be used with others. So, but this is not my choice. This is the organizers have done. Now, first, I would like to congratulate the government of UP and Department of Health for organizing this very important discussion. And I'm sure that whatever views are going to come out, they are going to help in shaping the policy. So I have been given certain background information about this, and I thought about it, and I will just share based on whatever is my expertise in whatever areas. So I would like to just talk about 2 points. One is that the design of these centers, how can they actually be successful? And the second issue which I would like to talk about is that in terms of socio-economic policy, how these centers should contribute or in what way uh, both things can feed into each other. For developing Center for Excellence, which are not merely just the name is Center for Excellence. And if we see our experience throughout India since independence, you see the collaboration with or mentorship from well-known institution is a prerequisite. Starting inventing the wheel on its own is not really the way it can possibly be done. You can create buildings, you can have funding, but the kind of soft knowledge which is required, that has to come from institutions who have gone into that particular path. So those collaborations, maybe within India or abroad. I know that John Hopkins University cannot collaborate with everybody, but there are other countries, other institutions who have better public health systems who can actually help in that. Second thing is that it requires attracting very serious talent. So, in fact, even before funding and everything, we have to have a policy to attract serious talent, the people who would be interested and willing to devote their time and energy, and at senior levels. So everybody cannot find Varghese Kurian for Amul, but we have to find those kind of people and make an effort to get them. Just few more things which probably I think would be, we can also look at some of these GCCs, Global Capability Centers, which many of the are working in the health areas where these private companies have developed these centers, and they are doing innovations and other things in healthcare centers. So the kind of interactions we can possibly have. We can also look at in terms of culture and in terms of the way the institution is going to run, probably the new structures would be required. And we have to focus on the experience of the citizens from their perspective, that what is actually required.
So as the scope of the center seems to be pretty wide, so very technical centers are supposed to be there in the background node was there who are working in very technical field like cardiology and other things. And there are centers which are more going to be working more in the policy space. So how these are going to integrate into each other and feed into each other, that is also to be thought about. So I think for this time being, that is, and
Ma'am, we would like to hear you too. Your opening remarks on how do we go about building these centers of excellence and which areas should it be addressing?
Thank you. It's a great opportunity. So, Center of Excellence, as already has been expressed, it needs certain kind of, background. Suddenly one Center of Excellence cannot come up. So, because it depends on the experience, reputation, and all. So, if we want to be high, we intend to have new centers, we have to plan very strategically. Availability of faculty, retention of the faculty, development of that faculty before it can be called a center of excellence. In my experience, the new aims, and the medical colleges in a health setting, those can be, from beginning they can be, planned to be developed as center of excellence. That will be a great opportunity. In health system, basically, a center of excellence has trinity of, mandates. Patient care, of course, because otherwise the medical institute will not operate. Education, mostly in center, excellence centers, education is a part, and research and innovation. So only research and innovation by itself, is not that possible in a medical institution. So we have to think of the all three, the structural requirements which will be needed, and national priorities. If you ask me, so the it depends. It is decided on the disease burden, the changing disease scenario, the epidemiological transition which is happening, the population age composition that is happening, like senior cares, then the, the stress factor, the lifestyle factor, mental health is again a very emerging issue. So nothing much is there if we think about center of excellence in that field. So those are areas which are there, and of course the traditional maternal newborn child health, that is again, because we have yet, though we have made a lot of progress, the last mile is not reached. So again there is a scope of, center of excellence there, being created over there. Adolescent health again is a very important emerging area. One is the critical care ecosystem, the emergency care. That again is, we need some centers of excellence that side. So if we go on thinking about it, climate issues on health, again, a lot of research, innovation, lot of thinking needs to go in that way. So their priorities are in this way. Of course, one center cannot provide, so we have to think differently for different issues depending on the availability of faculty, availability of structure, and many other issues. And these center of excellences, I think, have to be from the very beginning given some functional autonomy, so that they can, pursue new things. That is one major area, that, it cannot just go on doing the routine things. They have to be there. And the very important is a very important digital framework for that from the very beginning, so that everything can be data driven, digitalized. that is very important for COE to be set up. I think major area also is the impact assessment, what it is doing, how it is impacting the community. Basically, our all of our efforts in especially in government is community oriented, patient centric. So how it is impacting, and also their research achievements, like how many publications, how many patents. So that way we can decide and plan from beforehand that what is our expectation of the excellence center of excellence. Another thing is that it has a big role apart from these three is in mentoring the subordinate institutes, the center of excellence. So again, that we have to think whom it will cater to and from whom it will get the mentoring from. So all these aspects are to be carefully planned before we think about starting a center of excellence freshly. Thank you.
Thank you, ma'am. Now I move to Dr. Manish Chaturvedi. Dr. Chaturvedi, since you are coming from NIHFW, and this particular institute is not on the clinical side, it is helping us to helping us in the policy making aspect of health, if I'm not mistaken. So I would like to know from you what core competencies should an institute like NIHFW, a sister concern of it, should have, so that, and what institutional framework should it have so that it can provide valuable evidence-based inputs for our health policymakers.
Thank you, ma'am. And very good afternoon to all those who are hearing me. I'm really blessed that I have been chosen for this particular session. First, I want to congratulate the organizers for hosting such a great event or historical event. I'm sure that it is going to create a big impact on the Chikitsa Shiksha in future. As a whole, this is for the first time, not for the first time, but I realize one more thing, that in usual way, the public health and hospital adam always destined to have a postprandial session. This is a on lighter note. I am sharing my thought, ma'am. I am having a lot of thoughts about health policy center in UP. First, my suggestion, as we were created around 50 years back as NIHFW for supporting the health policy. And I realized that the autonomy with self-reliance should be the first point. Autonomy with self-reliance, and it should be restricted. We were designed in such a way that the director, deputy director, and the account officer should be from the open positions. The purpose was the ethical practices should be promoted in that particular organization. That was the purpose. Second point, these organizations should be research oriented. Otherwise, this particular position, this particular institute will phase out with time, because research should be the primary responsibility of these institutions, including the evaluation of existing policies and the programs. You may refurbish the SIHFW, which is still in the premises, in the vicinity of Lucknow. You may refurbish that particular institute as you want to achieve as early as possible by 2030 your outcomes, and you are expecting that they should start producing something. So you may refurbish, but simultaneously, I also suggest that cannibalization should also be the practice. You may pick and choose some of the smart faculty members or some of the smart professionals countrywide, and you may build up this particular institution as per your need and your objectives. Third, as ma'am has also specified, that young professionals or the youth is the upcoming more than 25% population of the country. And UP, which is having 22 crores of the population, more than that. My suggestion is we should focus on the young faculty members and we should build up their capability and capacity. I'm not a promoter of collaborating with international agencies or international institutions because my institution or my country is self-reliant and they are able to produce better performers in comparison to the foreign countries because I'm aware what they do and how they teach. Most of my faculty members are already trained in that way and they will be able to deliver in better way. This is my personal opinion, ma'am. The fourth suggestion is artificial intelligence is the upcoming area and for the achieving the capacity building of these young professionals, we may develop the connected hospital, concerned hospital, so that we may start communicating with each other. My students of one college should go to the other college as a form of a student exchange program. They should know the practices which are good in their institution, and we should start promoting the best practices in the state. In addition to this, ma'am, the knowledge hubs on the basis of quality performance and the Kaizen principles means continuous learning should be the key. This is again a proposal from my side. If we create the Center for Excellence for the purpose of knowledge hubs, if there is a need of information on a particular aspect, we should be able to target a particular institution that we will get this information from that particular institution. And advanced level of learning, not for the routine learning. Advanced level of learning is specified learning on a specific area. We may collaborate with the international agencies or the international institution, not for the routine one. Lastly, if we design our policies in such a way, then we may be able to achieve a good institution. We may replicate the Niti Aayog in form of Suniti Aayog in our own UP to make it Sarvottam from Uttam Pradesh. Thank you, ma'am.
Thank you, sir. I would like to listen to Dr. Arvind Mohan. Sir is a health economist of repute and a professor at Lucknow University. Sir, since you represent a very different facet to health sector, being a health economist, we would want to know what economic principles should guide the health policy making at state government level, and what do you have to say about identifying the areas where we want to build these institutes, areas as in the verticals, depending on which economic factors?
Thank you, Arya ji. Please allow me to think loudly. Let's look at the larger vision. And the larger vision is UP has to become a $1 trillion economy, India has to become a $5 trillion economy. Where does health sector come into it? क्या इसमें health sector कुछ contribute कर सकता है? That's the first question that needs to be answered. And when I look at the challenges that India face or challenges that Uttar Pradesh is facing, first important thing is that starting 1950s till now, the most important engine of India's growth, India's transformation was investment. And the maximum that it has been able to contribute is around 10% odd. What we are observing is the peak of investment happened in 2008, 2008-9. And now investment is going down. One of the important reasons is that India has been called young country because in those days, around 2008 odd, our average age was 25. Now it is moving towards 30. जो demographic dividend का advantage था वो धीरे-धीरे अब कम हो रहा है. And there are other reasons also. Meaning, for example, if you're looking at $1 trillion economy of Uttar Pradesh, it means you need a growth rate of 32%. Whatever effort we put in, investment at the moment can take you only to around 9% odd. Baki kahan se aayega? And health sector has a huge role to play. I think there are two major pillars that we need to look at. One important pillar is that capital is our challenge, wo nahi badh raha. But human capital is what we have not been looking at. If you are wanting to move towards 32% growth, one important ingredient will be TFP, total factor productivity. And that is where human capital will have to play a role. हमारा human capital तो पूरी तरीके से compromised है. एक large segment of population because of health एक बहुत बड़ा challenge है. That's one. Second pillar that we need to look at is whatever health expenditure is happening in Uttar Pradesh. There are different estimates, but on an average, anything between 80,000 crore to 1 lakh crore. I'll want to believe that it is slightly more than 1 lakh crore rupees of out-of-pocket expenditure which is happening in Uttar Pradesh. Various studies suggest कि हम जितना भी total expenditure कर रहे हैं, Government of Uttar Pradesh, Government of India, institutions like World Bank, all taken together, हम बमुश्किल 30-32% का actual expenditure health sector में कर रहे हैं. 30% odd expenditure is actually being made by the poorest to the poor. And that is what we call out-of-pocket expenses. ये story है penny wise pound foolish. हमारा सारा focus उस छोटे से expenditure पे है जो government and other so-called institutions are making. हम 70% को ignore करते रहे. Result, अगर हम see the last reasonable study that I saw, it suggests that close to around 50% people are first going to the quack. आम आदमी झोला छाप डॉक्टर के पास जा रहा है और जब वो केस बिगड़ता है, बिकॉज झोला छाप डॉक्टर हम सभी हैं, झोला छाप डॉक्टर. पैरासिटामोल, अभी डॉक्टर साहब ने कहा कि पीएचडी डॉक्टर है, मैं भी पीएचडी डॉक्टर हूँ, लेकिन मैं पैरासिटामोल ले लेता हूँ, बुखार होता है. This far, no further. And that's where the challenge is. Many of these RMPs, etc., many of these what we are calling the quacks, they go beyond that. जब केस बिगड़ जाता है, तब वो जा रहे हैं appropriate provider के पास, तब तक देर हो गई है, and it creates multiple challenges. Health, hospitalization in particular, is the biggest reason of families falling into poverty. ये हिंदुस्तान का सबसे बड़ा कारण है और हमें इस पे फोकस करना होगा. अगर हम इसको प्लग कर ले, ये जो 1 लाख करोड़ का जो वेस्ट हो रहा है, इसका मेजर हिस्सा क्वैक्स के पास जा रहा है, इनअप्रोप्रिएट केयर की तरफ जा रहा है, इसको हमें इंस्टीट्यूशनलाइज करना होगा. I think it is much more important than what the government is actually spending. तो पहला तो इशू ये है कि अगर आप सेंटर्स ऑफ एक्सीलेंस एस्टैब्लिश करना चाहते हैं, तो ये फंडिंग कैसे होगी? और ये सिर्फ हेल्थ सेक्टर की फंडिंग नहीं है. ये 1 लाख करोड़ रुपए इज एन इमीडिएट इंजेक्शन टू इंडियाज ग्रोथ स्टोरी, टू यूपीज ग्रोथ स्टोरी, जो आप अन्यथा आसानी से मोबिलाइज नहीं कर सकते. एंड देन इट विल आल्सो लीड टू लेसर कॉम्प्रोमाइज एज फार एज the quality of manpower is concerned. जो quality compromise है, वो significantly transform होगा. This is the second thing that I'll want to focus on. Third is, don't merely look at verticals. Also look at the layers. हम, for example, a decade back, Prime Minister's Advisory Committee suggests that as far as your PHCs, etc. are concerned, less than 10% people are seeking healthcare there. And that is leading to a situation कि आपके district hospital, etc. में बेशुमार भीड़ हो जाती है, आप handle नहीं कर सकते. Reason, people are straight away rushing there. And there is simple reason. For a long time, हमारा health need एक direction में गई है, health investment दूसरे direction में गया है. For example, your PSC doctor, हमने उसको, we did a study for the World Bank way back, and what we found was a PSC doctor, हम उसको जो काम दे रहे हैं, वो 8-10 दिन का काम 1 हफ्ते में दे रहे हैं. उसका जो work schedule हम बना रहे हैं, and this applies to number of lower functionary, right from the PSC doctor to the Director General Medical Health, हमने सबको inspector बना दिया है. Doctor कोई नहीं बचा. And that is creating a huge compromise. You'll have to create a cadre of health managers. Those could be specialized MBAs, etc. जो आपके इन सेंटर्स को हैंडल करें। पीएचसी के डॉक्टर को बेशुमार डेटा लोड करना है एंड सो ऑन। उस पीएचसी के डॉक्टर को कहीं मीटिंग अटेंड करनी है, कहीं इंस्पेक्शन करना है, एएनएम काम कर रही है कि नहीं कर रही है, सब सेंटर्स में काम, और उस जगह जगह घूम करके दैट इज व्हाट एक्सपेक्टेड हुआ। प्लीज फ्री हिम or her from this burden. Allow these PSCs to become truly the centers of excellence. See, हिंदुस्तान को और ये मल्टीपल रीजंस के लिए इंपॉर्टेंट है, हिंदुस्तान को और उत्तर प्रदेश को हाई एंड केयर चाहिए, लेकिन मॉर्टेलिटी अगर आपको चेक करनी है, मॉर्बिडिटी चेक करनी है, तो पब्लिक हेल्थ का जो कटिंग एज है ये सबसे इंपॉर्टेंट है। हम वहां पर कैसे सेंटर ऑफ एक्सीलेंस करेंगे? यू विल हैव टू क्रिएट अ कनेक्ट, नो डाउट यू नीड सम रिसर्च सेंटर्स एटसेट्रा। ये पहला रीजन है। आपको अगर मॉर्बिडिटी कम करनी है, मॉर्टेलिटी कम करनी है, यू विल हैव टू फोकस देयर, और हमारे सेंटर्स ऑफ एक्सीलेंस को उसके हिसाब से फोकस होना होगा। तो यू विल नीड centers of excellence for financing healthcare, centers of excellence, maybe it could be the same, आपके public private partnerships कैसे होंगी, उसके लिए भी आपको centers चाहिए, और ये जो cutting edge है, ये 10% से बढ़ के 80% कैसे होगा, इसके लिए आपको focus करना पड़ेगा। These are critical areas. If you are really wanting to transform healthcare in Uttar Pradesh, you cannot ignore the layers. तो हम ये जो centers of excellence होंगे, उनको इसके साथ कैसे कनेक्ट करने जा रहे हैं, दिस इज अनदर एस्पेक्ट। ऑल्सो आई फाइंड आपके हम पीजीआई एंड लार्जर हॉस्पिटल्स की बात करें, जिनको कुछ हद तक हम सेंटर्स ऑफ एक्सीलेंस बना चुके हैं, ये जो सेंटर्स ऑफ एक्सीलेंस हैं, वील हैव टू अंडरस्टैंड, हमने कभी कोई एक्सरसाइज ही नहीं किया। आज की तारीख में हमारे पास पब्लिक प्राइवेट पार्टनरशिप की कैपेसिटी नहीं है, हमें मालूम ही नहीं है कि ये जो लार्जर सेंटर्स है इसमें क्या प्राइवेट पार्टिसिपेशन आ सकता है। we have never measured that, हमने उस तरीके से कॉस्टिंग ही नहीं की है। The truth is your tertiary care, major part of it is where much of private investment can come. For example, आप जब रिसर्च पे फोकस कर रहे हैं, वो पब्लिक सेक्टर को या गवर्नमेंट को will have to take care of that. Rest of it, particularly the hospital part of it, can we privatize that? And same can apply to your district hospital, same can apply maybe to your CSCs and PSCs. Rest, I think I'll want to reflect subsequently. Thank you.
Thank you so much, sir. Now I move to Dr. C.M. Singh. Dr. Singh is heading a Center of Excellence, RML Institute of Medical Sciences in Lucknow. So being practicing medical practitioner and a doctor, so I would like to know from the clinical side of it, when we build a clinical center of excellence, uh, how do you address the various issues concerning infrastructural, academic, and governance related issues when you run such a center or establish such a center? And also, how do you address the shortage of doctors that we presently face in the public health system? And how do we address it?
Okay, thank you, madam. Thank you for calling me. एक्चुअली अगर मैं सीधे स्टेट क्वेश्चन पे आऊँ, जो पहला क्वेश्चन जो आपने हमें दिया है कि हाउ मेनी सेंटर ऑफ एक्सीलेंस आर रिक्वायर्ड इन स्टेट ऑफ यूपी, एंड सेकंड व्हाट शुड गाइड दीज आइडेंटिफिकेशन। तो अगर हम बात ये करें कि कितने सेंटर ऑफ एक्सीलेंस यूपी में होने चाहिए, तो पहला कोई एक साइंटिफिक वे नहीं है ये आइडेंटिफाई करने के लिए कि एग्जैक्ट नंबर क्या होना चाहिए, लेकिन जो हम जो स्टार्ट कर सकते हैं, अभी अगर हम यूपी की बात करें तो लखनऊ में 3 सेंटर हैं, KGMU, RML और SGPGI, जो टू सम एक्सटेंट आर वर्किंग एज ए सेंटर ऑफ एक्सेलेंस फॉर डिफरेंट डिजीजेज। अगर टोटल हम यूपी की बात करें तो वी कैन स्टार्ट विथ 8 मेडिकल कॉलेजेस, 6 medical college, old medical colleges like Gorakhpur, Agra, Allahabad, Meerut, and Jhansi. 6 old medical colleges. They have the potential, they have the infrastructure, except manpower. So they can be converted in center of excellence. Actually, for which diseases we require the center of excellence, we can think we require the center of excellence for cardiovascular diseases, We require Center of Excellence for Onco Services. We require Center of Excellence for Neuroscience centers we require. And some Center of Excellence for transplant also. We know the patients from UP, if any patient require liver transplant, they used to move outside the UP. So we require the Center of organ transplant also. For that, what I can suggest, may not be a right forum, but what I am thinking from the day you invited me, we can start at least our old medical college. Since I am graduated from Kanpur Medical College, that is a State Medical College of Uttar Pradesh, and post-graduated from MLB Medical College, Jhansi. And after that, I worked as a senior resident in BHU. And after that, I started working in Rural Institute of Medical Sciences, SAFAI Itawa. And in 2012, I moved to All India Institute of Medical Sciences, Patna. So basically what I can say, I have seen my status of my state medical colleges, and I have worked in institute, so-called Institute of National Importance like AIMS, and now I am working in RML. So what I can suggest, we should go just like making these institutions autonomous, at least these 6-7 institutions autonomous, and instead of having the principal, we we should go as model of SGPGI RML. We should create the post of director, and we should pay the same amount because the doctor of RML SGPGI is getting to overcome the problem of manpower, particularly the faculty. By this we can start. Infrastructure somehow they have. They need more reinforcement, and by that we can start center of excellences. Like discuss about Kanpur Medical College, we are having a good cardiac center over there. We can start the neuroscience center over there. We can start the center of excellence for trauma also over there. Similarly, in Allahabad Medical College, we can start some center of excellence for onco surgery or for again neuroscience center. So in nutshell, I want to say we can start with 6 to 8. You can 9 earlier. In beginning only, I told you there is no fixed number. There is no any criteria to fix that number. But what we are having in UP, on basis of that, we can start to 6 to 8 center of excellence. To some extent, we are having, and what should be the model I have suggested. We have to make them autonomous, not autonomous like autonomous medical colleges, which we are creating at district level. Autonomous means it should be like SGPGI or RML or AIMS, you can say, and open post of director should be there, where a person from SGPGI, AIMS Delhi, or from anywhere from country, he can come over there and he can serve. And the problems which these institutions are facing, if I am allowed to say, like private practice and all those things can be taken care of that to some extent, and ultimately these institutions can work as a center of excellence. This is my view. And if I have to start, if I have to say, since I am a public health expert, and many I'm seeing in front of many people in front of me sitting a public health expert, they very eagerly and very urgently they might be feeling from inception. I am also have that feeling. We should have a center of excellence for public health also. The public health is very much required, particularly in this state. So we should have 1 or 2 public health center of excellence for public health, and some other center can be cooperated, can be incorporated, can be connected with those center of excellence of public health. These are my view in nutshell. If any other question, I am ready. Thank you.
Thank you, sir. Sir, you very rightly told us the challenges and the shortfalls which are there in creating and running a center of excellence, because you are heading one such center, and what should be done. I would like to move to Dr. Harsh Sharma again. Sir, you are from a different field, and you can perhaps guide us as to how health institutes and excellence centers in health can leverage the social capital, and what socio-economic agenda should they be following?
Yeah, Thank you for your question. You see, at the end of it, whatever we do, the outcomes are going to decide that are we moving in the right direction or not. So health outcomes for most of our people, if not for all, is something that is supposed to be the parameter against which everything has to be judged. So is overall mortality rate, child mortality rate, or average age, all these things are there. However, in this debate, sometimes we move towards technical solutions, sometimes we move towards more of administrative views or some kind of structural changes we keep on talking about. But one area which often gets neglected is the way our society is structured and the how that structure of the society in a way uh, creates predetermined outcomes for a certain group of people, no matter whatever kind of overall impact you will like to have. So every strata of our society is not does not see the health issues in the same manner, and every strata of our society does not get the same kind, and it is not merely an economic issue. uh, I think Professor Mohan was mentioning that one of the main reason for poverty is that suppose somebody gets ill and the whole income of the family goes away. But if there are studies, I won't like to talk about them, but you will see that the social issues, the caste, gender, regional differences which are there, especially in a state like UP, 75 districts, and you go from Bundelkhand to the Noida or NCR, you will find very, very different kind of challenges. So looking from the perspective of the citizen uh, in that particular context, and the role of these center of excellences is going to be to weave that into a kind of a policy framework. I'm talking from policy perspective. So it is really very important that we look at that particular challenge. Uh, Prior to this, I was with Administrative Staff College of India, and then I was director of Center for Innovation in Public Systems, and we did some studies, especially in Telangana and Andhra Pradesh. And we found that if we built in social understanding and knowledge into health policy, overall outcomes actually improve. So I believe that that is what some of these center of excellence should try to do, or at least they should be that kind of integration which should be possible.
So I'd like Dr. Arvind Mohan to share about the disease burden and how that should determine which areas should we be addressing through our policies and these institutes.
When you look at the disease profile, what we find is, and again, I'll want to connect it with uh, demographic dividend. See, whatever investment India is generating, almost 90 to 95 investment is being financed by domestic savings. Only close to 3, 4, 5% is what is being financed by so-called foreign investment. And this demographic dividend is there because working population in India, being a young country, working population is larger than the dependent population. And working population we normally calculate between 15 to 60. When you are looking at this particular age group, if you're really wanting to achieve what we are wanting to achieve by 2047, disease profile in this group, the largest burden is actually coming from uh, lifestyle diseases, cardiac and related areas, COPD and all that, cancer, and some part is diarrhea. Diarrhea is also important for below 15 also. So almost more than 50% of disease burden is coming from here. And when you are looking at the higher age group, again, these remain important along with some geriatric care kind of thing. So these exactly, because if you're comparing between 1990 to the data that we have, I think we'll have data for up to 2019 odd firm data. It suggests that the disease profile is significantly changed. Lifestyle diseases like cardiac care, like respiratory diseases and cancer, etc., diarrhea, they, I think their share in particularly this particular group 15 to almost 69, their share in the burden is close to 56%. So I think this is what you'll have to focus in particular. Also, other groups also, diarrhea remains important, particularly for children below 15. There are neonatal care related other interventions that we'll have to look at. Also, what we'll have to think about and intervene. Also, what we'll have to think about and maybe intervene is healthcare, a large segment of it is truly not about clinical care. It is about social practices. As a matter of fact, much of mortality, particularly in neonatal care and mother and child care, what we observe is merely because a rusted blade was being used, it led to significant neonatal mortality. So much of your healthcare, much of disease burden, both mortality and morbidity, can be brought about by social change. So as Dr. Harsh was also mentioning, I think this is an important area that you'll have to have center of excellence. So I think if you're looking at the disease burden and maybe the idea of social change, we have achieved significantly. I think UNICEF led campaigns around the Tarai area, particularly Gorakhpur and around, meningitis, Japanese encephalitis. This again is a huge burden. We'll have to focus on that. But there we have seen that social change in that area significantly brought down the disease burden. But there certainly you'll have to focus on malaria, particularly in the Tarai region, malaria, encephalitis, and the Japanese encephalitis. So you'll again have to focus as far as your center of excellence concerned. So I think when you are looking at disease profile, we'll have to keep in mind that what we are focusing on and how it will contribute to the larger story of the $1 trillion economy that UP is talking about.
Thank you, sir. Dr. Chaturvedi, one question I would like to ask you personally is, being an institute involved in public health research and inputs for policy making, what are the essential components, like, the very basics, the nuts and bolts, the curriculum, the field training, the research modules, governance structures, which are followed in NIHFW, and the best practices which we can emulate in UP?
Sure, ma'am. Thank you for this question. This is likewise a very important question. I wish to inform that my institution is doing a lot of work in field of public health. We had created this particular institute of NIHFW around 50 years back, just to support for the purpose of national health policy. And most of the national health policies were designed in my premises. That's the glory attached with my institution. Somehow, because of some administrative issues, we are phasing down. Our number of faculty members are reducing, but still, we are contributing a lot. We are supporting Government of India in many evaluations. So evaluation is the key, which can be supported to your institution. Second, 50 years around back, we have started a specific course in my institution that was MD in Community Health Administration, which was a unique course. Why so? Because it's a combination of public health as well as of hospital LADM. So with the theme of this panel, this course was designed around 50 years back, and it's an NMC recognized course, and we are getting students through NEET. And these students are going to contribute at various level in the ministry and in the various other organizations. Some of them are working as a public health professional, some of them are working as hospital LADM, because our specific need of public health as well as of hospital LADM. Hospital Adam is a specified area, is a focused area which contributes inside the institutions, while the public health glorify in the vicinity of the community. Our public health focus, sorry, our public health focus says that the doctor should be at the doorstep of the community, not the doctor. The healthcare workforce professionals should be at the doorstep of the community member, so that the number of hospitals should be reduced. And that was the theme of my public health section or the community medicine department. Sir just added, Arvind sir just added that we should have the public health managers. And that is the reason, that was the vision we have added this community health officers in the Ayushman Arogya Mandir. We are creating Ayushman Arogya Mandir in the same place of the sub-centers. We are upgrading them to the Ayushman Arogya Mandir. We are adding the workforce with the help of the CHOs, and these CHOs are working in line with the medical officers. So we are upgrading the system. Simultaneously, the out-of-pocket expenditure is reducing. Somehow it was at a level of 70 or 80%. Now it is reduced down. It is supposedly the responsibility of national health account, but now it is reduced down to around 35 to 40%. So we are increasing, we are providing the services, but my humble submission that the tertiary care or the quaternary care institutions should be some. Not all institutions should be the quaternary institutions or the super specialty institution. We should provide the super specialty services at some of the institution, and we should focus, we should fund them accordingly. All the funds should not be allocated to every institution, so that no one will be able to deliver at least the basic services which are required to be performed at that particular level. These are my humble submissions, ma'am. Thank you.
Moving to Dr. Sumita Ghosh, I have one more question for you. Ma'am, you are from Niti Aayog. What help and what kind of support can Niti Aayog give us when we chart this course of thinking about building these institutions? We'll have a short-term plan and a long-term plan. So what kind of support can we expect from Niti Aayog in terms of technical inputs and other things?
When we are thinking about Viksit UP by 2047, the strategy, the implementation plan, the targets. So every time, this we are doing this for different states at Niti Aayog. So when UP came, we did a framework for that. See, Niti Aayog is the central think tank, like strategizing long-term, short-term plans for the country. And most of the states, they have these state institutes, SITs, State Institutes of Transformation. They are located at the states, supported by the State Support Commission, State Support Mission of Niti Aayog, and they are in UP too. And they can be very active partners, for your strategizing how, where, what should be done, what should be the targets. Then once the strategizing has been done, what are the areas you want to improve? Like here we are discussing about COE, Center of Excellences. So after this is done, these state institutes, they are also mandated to do, the data, the analysis, the review, the monitoring, the midterm correction. They can, in every area of, actual on-ground implementation, measuring the progress of the plan. So these institutes can actually, they have the mandate also to work with the state government, and they can be of great help. Of course, Niti Aayog is there. Niti Aayog at the central level, the meeting of the governors, high-level meetings, the governing council meetings. So there things can be discussed, anything which are needed, that can be done. Again, the Niti Aayog as well as SITs, they are have the network and they have the liberty of introducing lateral expertise. So if you need expertise in certain fields, that can be sort of done through the SITs and the networking. Because see, research, center of excellence, they all need national networking first of all. Like research networks are there, research collaborators are there, ICMR, DHR, DBT, so many avenues which can give extramural fundings, extramural supports, mentoring, all this, the research environment creation. So that can be helped, and these academic experts that can be inducted into your plan so that the plan can, be made proper, as well as it implementation is really governed, the data is analyzed, reviewed, and it takes, the right direction. Even mid-course correction can be done. So these are the various way and the NITI and the SITs can support the states for your Viksit mission and vision.
Thank you, ma'am. And a last question I want to pose to Dr. CM Singh. सर, आपने भी बताया कि आपका कैसे आप देखते हैं कि पहले जो हमारे 8 मेडिकल कॉलेजेस पुराने हैं जो इस्टेब्लिश्ड हैं, हाउ उनको हम लेकर के चलें. तो सर, आई वांट टू आस्क यू कि जब ये इंस्टीट्यूट्स फंक्शन करेंगे तो किस तरह का कोलैबोरेशन इंस्टीट्यूट्स में होना चाहिए, रेफरल सिस्टम क्या होना चाहिए. एक अगर स्टेट की बात करें, यूपी की बात करें, तो अगर भविष्य में हम 5 साल में 10 साल में हम ऐसे 8-10 सेंटर्स बनाते हैं, किस तरह का उनके बीच में एक इकोसिस्टम होना चाहिए, उस पर आप कुछ बोलें प्लीज.
बिल्कुल इम्पोर्टेंट क्वेश्चन है मैम. डॉक्टर चतुर्वेदी ने बोला था कि हम लोग सेंटर ऑफ एक्सीलेंस स्टेप वाइज बनाए. बहुत सही बोला था, क्योंकि इंफ्रास्ट्रक्चर हमें डेवलप करने में टाइम लगेगा. दूसरा, अभी एक अच्छी बात क्या है यूपी के लिए मैम, कि हम हर जिले में एक डिस्ट्रिक्ट मेडिकल कॉलेज बना रहे हैं. हम पब्लिक हेल्थ की बात नहीं कर रहे हैं ज़्यादा, क्योंकि वैसे तो पब्लिक हेल्थ का एक्सपर्ट मैं हूँ, लेकिन उसकी बात काफ़ी हो चुकी है कि स्टार्टिंग फ्रॉम सब सेंटर, PSC, CSC और डिस्ट्रिक्ट हॉस्पिटल में क्या क्या चैलेंजेज हैं, और उनको स्ट्रेंथन करे बिना हम फिर आगे का, बेसिकली आगे का डेवलपमेंट बहुत प्रोडक्टिव नहीं होगा. हमें उन पे तो काम करना है. मैं उस पर अभी नहीं जा रहा हूँ, मैं मेडिकल कॉलेजेस पे स्टिक करता हूँ, सेंटर ऑफ एक्सीलेंस पे. तो उसमें हम देखें कि हर डिस्ट्रिक्ट में एक मेडिकल कॉलेज ऑलमोस्ट है हमारे यहाँ, या जल्दी से होने वाला है. तो ये जो मेडिकल कॉलेजेस हैं, ये फीडर सेंटर की तरह यूज हो सकते हैं फॉर दिस सेंटर ऑफ एक्सेलेंसेज, जो मैं 7-8 प्रपोज करने की बात कर रहा था. वहाँ पे अगर जैसे एक छोटा सा एग्जांपल दें, अभी यूपी में एक बड़ा अच्छा काम हो रहा है, शायद बहुत लोगों को पता नहीं होगा, स्टेमी केयर करके. हमारे बीच में प्रोफेसर भुवन तिवारी अवेलेबल हैं, जो RML के स्टेमी केयर के नोडल पर्सन है और कार्डियोलॉजी के हेड ऑफ डिपार्टमेंट है. ही इज रनिंग बेसिकली एट RML. उसमें क्या कर रहे हैं कि हमने 10 डिस्ट्रिक्ट्स लिए हुए हैं यूपी के, मेनली ईस्टर्न डिस्ट्रिक्ट हैं टिल आजमगढ़. वहाँ पे क्या है कि अगर किसी भी अगर पेशेंट को अगर MI है, मीन्स चेस्ट पेन है, वो नियरेस्ट सेंटर में जाता है, एटलीस्ट CSC डिस्ट्रिक्ट हॉस्पिटल जहाँ भी जाएगा. तो यहाँ पे अगर ज़्यादातर डॉक्टर बैठे हैं तो जानते हैं कि अगर उन्होंने ECG कर लिया, तो हमारे बहुत सारे अभी पेरिफेरल लेवल पे बहुत सारे डॉक्टर बहुत कॉन्फिडेंटली ECG नहीं रीड कर पाते हैं. उनको कुछ लगता है बट कंफर्म नहीं होते हैं. तो खैर उनको ट्रेनिंग दे के उनको ECG रीड करना सिखाया. उसके बाद वो जैसे उनकी ECG आती है, वो एक व्हाट्सएप ग्रुप पे सेंड करते हैं. वो व्हाट्सएप ग्रुप RML के पास है, जो किसी न किसी के पास होता है, जो हमारे RML की टीम है. वो वहाँ से तुरंत बोलते हैं ये कि ये स्टेमी है, ST एलिवेटेड मायोकार्डियल इन्फेक्शन है. उसके बाद और तुरंत ये भी बोलते हैं कि इसको आप थ्रोम्बोलाइज करो. गवर्नमेंट ऑफ यूपी ने सारे इन सेंटरों पे फ्री ऑफ कास्ट अवेलेबल कराया है टेरेक्टिव प्लेस को, जो करीब 20-25 हज़ार रुपये का इंजेक्शन है, बट फ्री ऑफ कास्ट अवेलेबल कराया है. वो पेशेंट वहाँ पे थ्रोम्बोलाइज होता है, जो हम कहते हैं कि अगर 4 घंटे के अंदर थ्रोम्बोलाइज हो गया तो उसका आउटकम कुछ और ही होता है. तो वहाँ थ्रोम्बोलाइज हो गया. उसके बाद उसका रेफरल लिंक बना हुआ है, वो सीधे RML आता है, और अगर उसको एंजियोग्राफी एंजियोप्लास्टी जो भी करनी होती है वो RML करता है. इस तरीके से करीब अभी थोड़े दिनों पहले शुरू हुआ है, 150 एंजियोप्लास्टी RML कर चुका है. और कई हज़ार पेशेंट को बेनिफिट हो चुकी है कि उनको पेन हुआ, ईसीजी हुआ, बट उनको एमआई नहीं है। तो उनको तुरंत वहीं पे एडवाइस मिल गई कि इट्स नॉट एमआई, जो भी उनका अपना नॉर्मल मैनेजमेंट है चेस्ट पेन और बाकी चीज़ों के लिए वो करें। तो इस तरीके से अगर हम एक प्रोग्राम के थ्रू, टेक्नोलॉजी के थ्रू, अगर डायरेक्ट बहुत पेरिफेरल लेवल के सेंटर से हम जुड़ रहे हैं, सीएससी से, पीएससी से और डिस्ट्रिक्ट हॉस्पिटल से, तो हम अगर रेफरल की बात करें, हम जो फीडर मेडिकल कॉलेज, सॉरी फीडर नहीं कहना चाहिए, जो ऑटोनोमस इंस्टीट्यूट हैं हमारे डिस्ट्रिक्ट लेवल पे जो मेडिकल कॉलेज हैं, उनको हम कनेक्ट करें पीएससी से, सीएससी से और डिस्ट्रिक्ट हॉस्पिटल से, और इन मेडिकल कॉलेजेस को हम सेंटर ऑफ एक्सलेंस से कनेक्ट करें, तो इससे काफ़ी प्रॉब्लम सॉल्व हो सकती है। कहना जरूर आसान लग रहा है, करना थोड़ा मुश्किल होता है, बट ऐसा नहीं है कि सीएससी और डिस्ट्रिक्ट हॉस्पिटल से डायरेक्ट सीओई को नहीं आ सकते हैं। उसके हमें एक मैकेनिज्म डेवलप करना चाहिए कि आप पहले उन डिस्ट्रिक्ट अपने मेडिकल कॉलेजेस पे भेजो जो डिस्ट्रिक्ट लेवल पे हैं, उसके बाद अगर वहाँ पे डॉक्टर्स फील करता है तो यहाँ पे करें। और यहाँ पे हमारे जो सेंटर ऑफ एक्सीलेंस है, वहाँ पे वेबसाइट पे बिल्कुल विजिबिलिटी होनी चाहिए कि हमारे पास कितने आईसीयू बेड हैं, उसमें कितने वैकेंट हैं, एचडीयू बेड कितने हैं, कितने वैकेंट हैं, नॉर्मल बेड कितने हैं, कितने वैकेंट हैं। ये सारा एक डिस्प्ले हमारे पास होना चाहिए वेबसाइट से, जिससे कि जो मेडिकल कॉलेज हैं वो वहाँ पे रेफर कर सकें। इस तरह का एक लिंकेज बनाना होगा, मेरा मानना है। थैंक यू।
Thank you, sir. Very valuable inputs. At the end, I would like everyone to also, we have a short video message from Professor Sanjay Zodpe. He is president of PHFI. I had requested him to join us for the session, but due to some prior commitments, he could not join. He has sent us a video message. Please usko play kar dijiye.
To address this distinguished gathering. Namaskar. I am honored to address this distinguished gathering at the Stakeholder Consultation Conference for Vikasit Uttar Pradesh 2047, focusing on creating new centers of excellence in public health. My sincere thanks to the organizers and to Madam Aryaka Khuraji, Special Secretary Medical Health and Family Welfare, for her leadership. I also express my regret for not being able to participate in person owing to some prior commitments. I am recording this message today from the campus of Indian Institute of Public Health, Gandhinagar, an institution born from visionary leadership and long-term investment. Speaking from IIPH Gandhinagar, I must acknowledge the crucial role played by the Honorable Prime Minister Shri Narendra Bhai Modi ji when he was the Chief Minister of Gujarat for providing land and facilitating the establishment of this institution, now recognized as India's first dedicated public health university established through the state legislation. He demonstrated how transformative leadership builds institutions that serve the generations. As Uttar Pradesh builds its roadmap for Vikasit Uttar Pradesh 2047, three strategic efforts may help accelerate the progress. The first of these could be to develop the centers of excellence in public health and workforce development, create multidisciplinary hubs integrating public health, medical, nursing, Ayush, and digital health education, establish simulation and skill laboratories, and connect them with field practice sites across the districts. The second effort can be to make quality improvement and faculty development a central agenda, strengthen capacity-based education, and also ensuring competencies and continuous professional development, expand digital learning platforms, mentorship networks, and academic partnerships to enable consistent quality across our institutions. The third effort can be to build a robust ecosystem for research, surveillance, digital health, and data-driven planning, encourage partnerships between academia, government, and industry to enhance innovation, scale digital platforms and AI enabled tools to improve service delivery and public health intelligence. Swasth Bharat is the driving force behind Vikasit Bharat. Strong public health systems, disease prevention strategies, financial protection, and skilled health workers help us to build a productive and resilient population. Better health leads to higher workforce participation, stronger learning outcomes, and reduced poverty and faster economic growth. Good health is not just a social priority, it is a strategic economic investment that will accelerate the journey towards becoming a Vikasit Bharat. Thank you so much.
I would like to thank each one of you. I have got some very valuable inputs. I have taken notes also on how we should go about making our vision document of health department for Viksit UP 2047 as far as the chapter on creating centers of excellence goes. As each one of you has given us great insights into this, that first of all, we should not be in a hurry to make many such institutions. It should be a very strategic intervention and not mushrooming of a lot of institutions without proper budgetary support and other logistical support. We should, as Dr. Arvind Mohan rightly said, that we should be analyzing the disease profile and focusing on creating centers which would reduce the out-of-pocket expenditure of the common man. Dr. Sumita Ghosh talked to us about the verticals on which these centers should be designed, and the pressing need for the diseases which are upcoming now, lifestyle diseases and the cardiovascular diseases, which for a huge chunk of our population is facing issues. Dr. CM Singh talked to us about very pertinent points about how to run these centers, because he's running one, and he's also addressed the autonomy point of it, how autonomous these institutions should be, and also the referral system that he has addressed, how it should be designed. Dr. Harsh Sharma has spoken to us about the social perspective of health policy making, how our religion, caste, gender, and geographical disparities affect the health status of a common citizen, and how we should be able to integrate them when we make policies for our citizens. And Dr. Manish Chaturvedi has told us about how NIHFW has been a successful example in creating such an institution, backed by meticulous planning and a very strong curriculum. So I thank each one of you for giving us these valuable inputs. And personally, for me, it has been a very enriching session. I now throw the floor open to our audience members. I think that we have a member who would like to ask a question. Sir, I'll come to you. Please, up, if you can come ahead and take a mic.
हेलो नमस्ते मैं डॉक्टर अरुण श्रीवास्तव डीन एकेडमिक केएमसी मेडिकल कॉलेज महाराजगंज से हूँ सेंटर ऑफ एक्सीलेंस की तो हम बात कर रहे हैं लेकिन एक चीज मैंने देखा कि हम लोगों ने जितनी भी बात की उसमें प्रिवेंटिव पार्ट पे हम लोगों ने बहुत ज्यादा जोर नहीं दिया और मेरे ख्याल से सेंटर ऑफ एक्सीलेंस के ही इक्वल एक्सीलेंस इन प्रिवेंशन भी होना चाहिए क्योंकि देखिए आप हम लोगों ने कोविड को इतना झेला और जो बर्डन हमारे ऊपर आने वाला था अगर हम लोगों ने प्रिवेंटिव पार्ट को नहीं किया होता तो चाहे कितने भी बड़े हॉस्पिटल्स होते चाहे कितने भी बेड होते और हमारे पास वेंटिलेटर होते हम लोग कंट्रोल नहीं कर सकते थे तो एक और हम प्रॉब्लम्स को जो क्रिएट हो रही हैं उनको तो ठीक है हम उनके लिए पूरा इंतजाम कर रहे हैं लेकिन आग जहां से लग रही है अगर उस पार्ट पे अगर हम नहीं ध्यान दें क्योंकि देखिए हम अपने बजट का अगर 10% भी प्रिवेंशन वाले पार्ट पे लगा दे प्रिवेंशन वाले पार्ट पे मेरा मतलब केवल ये है कि जितने भी हमारे फील्ड्स हैं लाइक रूरल में मैंने अभी फैमिली एडॉप्शन प्रोग्राम कराया था अपने बच्चों को तो मैंने देखा वहाँ पे कि ऐसा नहीं है कि डायबिटीज केवल अपर क्लास और इनमें ही है या सेडेंट्री हैबिट्स में ही है इवन जो वर्क कर रहे हैं फील्ड्स में उनमें भी हम लोगों ने देखा 400 पे उनका शुगर लेवल है तो ये न मानते हुए कि बीमारी कहाँ पे है कहाँ नहीं प्रिवेंटिव पार्ट को अगर हम अप्लाई करते हैं रूरल लेवल एज वेल एज अर्बन एंड इन ऑफिसेज आल्सो इन स्कूल and wherever the stress is being created जो भी हमारे स्ट्रेस के फील्ड हैं, अगर
Thank you,
उसमें हम
doctor.
पार्ट करें तो
Yeah.
मेरे ख्याल से ये
Very
ज्यादा
बहुत
फर्क
आपका valuable suggestion है.
Thank you.
We'll include it in our document, and I think prevention is better than cure.
Yes,
सब कहते हैं prevention is better than cure, so it's a very pertinent topic. आपको Mike,
One question, please. One question.
yeah, just be very brief because we are getting late for the group photograph also.
Yeah, a very good afternoon. I am Dr. Amit Singh. I am the medical superintendent at UP University of Medical Science, SAFI. In lines with what Dr. CM Singh has told, like about talking about making autonomous these 8 medical colleges. At the same time, I feel decentralization of these COEs is important. We can't expect the clutter of centers coming up at SCR, catering to patients from far out of reach areas like Mirzapur, Badaयूं and all. In that aspect, I would want to really add on to that. Whenever you make a policy in these things, like please do not forget our UP UMS SAFI. Like we have an excellent infrastructure far above all these 8 colleges we're talking about. So it can serve as a center for the Western population, Bundelkhand region and all. That's number one. Number two, when you talk about making COE for transplant, before that, we have to empower trauma centers with 50 to 100 beds as centers for organ harvesting and banking, which can serve as feeders for harvest transplant at KGUM and other places and all. So we need to talk about that first, harvesting, banking, and then transplant. And even in that, we have to decentralize things. Thank you.
Thank you.
Just a brief comment, and please allow me to play the devil's advocate. My personal take is, हम हर district में, yeah. See, my take is that हर district में हमें medical college नहीं बनाना चाहिए. I'm just trying to play the devil's advocate. We need high-end hospitals. The best possible hospital should be opened. See, where is the faculty available? We are talking about creating centers of excellence. So what is the idea of having a medical college in every district, because you cannot have the kind of faculty which is required? My alternative suggestion is, for example, KGMU and many other such institutions, double their strength, create more capacities there. You'll have better faculties here. You'll get better doctors. Doctor is something which even a country like Canada, which was willing to pay the moon, was not able to take the doctors to the north. इंडिया का भी वही चैलेंज है, रूरल एरियाज में हम डॉक्टर नहीं पहुंचा पा रहे हैं. हमें मैन पावर चाहिए, लेकिन वो alternate model से create हो सकता है. Create best possible hospitals in every possible district, but not necessarily the medical college. Just a comment. Wanted to add this.
आप प्लीज बैठ के बोल लीजिए.
नहीं, खड़े होकर बोलना अच्छा लगता है, टीचर हूँ इसलिए. मैडम, सेंटर ऑफ एक्सीलेंस की जहां तक बात हो रही है, अगर हम 2047 तक की सोचते हैं तो 2-3 चीजें बड़ी प्रेवलेंट है. जैसे पॉपुलेशन बढ़ेगी तो सब सेंटर भी बढ़ेंगे, पीएससी भी बढ़ेगी और हमारी सीएससी भी बढ़ेगी और डिस्ट्रिक्ट हॉस्पिटल शायद बढ़ जाए. सेंटर ऑफ एक्सीलेंस जो भी है आज की तारीख में, अगर हम जैसे पीजीआई को देख लें, केजीएमसी को देख लें या बड़े बड़े हॉस्पिटल को देख लें, हमको सर जैसे आपने कहा कि डिजीज बर्डन की जहां स्टडी करनी है, हमको उनके ऊपर क्लाइंट लोड का भी असेसमेंट करना चाहिए. फॉर एग्जाम्पल, अगर केजीएमसी में क्लाइंट लोड ओपीडी बहुत ज्यादा आ रही है, तो वो ओपीडी कैसे हम शिफ्ट करें, और प्राइमरी केयर और सेकेंडरी केयर के स्पेशली ये 2 टाइप के जो पेशेंट हैं उनको कैसे हम डाइवर्ट करें. आज की तारीख में सर अर्बन एरिया में भी प्राइमरी हेल्थ सेंटर भी है, कम्युनिटी हेल्थ सेंटर भी है. अगर हमको सेंटर ऑफ एक्सीलेंस उनको फोकस करें तो संभवतः वो आपके बलरामपुर हॉस्पिटल में बुखार के लिए तो नहीं जाएंगे. और तीसरी बात बहुत इंपॉर्टेंट है, आगे आने वाले समय में जो टेक्नोलॉजी आ जाएगी, एआई वगैरह भी आएगा और हमारा टेलीमेडिसिन भी आएगा, तो हो सकता है ऐसी स्थिति में हमारे पास डिजीज बर्डन और क्या कहते हैं क्लाइंट बर्डन कम होगा. थैंक यू वेरी मच.
Ma'am, just a comment from my side, and a brief comment on the 3 questions. The first one was in relation to the preventive health. My community medicine friends are sitting over here, and even my senior Dr. CM Singh is here. I am also a community medicine guy. Community medicine department looks after around 40,000 population. They caters to 40,000 population. They maintain their records. They provide clinical care as and when required to them. And it makes a sense of around 3 crores public is catered by them in UP, which is having 22 crore population. So we have a good reach with the least of uh, funds which we require, except the transport and the manpower is already there. They are serving too much by reaching there at the doorstep at the community level. The second one, we don't have the data. We are in morning, someone was saying that we have 1.5 beds per thousand population. Do we have 6 lakh beds? I don't know whether we have or not. But we want to achieve a bad number of 10 lakhs or 12 lakhs or 15 lakhs. Who is going to manage them? Simply increasing the number of beds is simply for the purpose of hospitality. No, it's for the clinical care. Do we have the clinical care specialist in hand? So we should focus in a phased manner. We should focus a stepwise manner. We should focus in the same way, whether we have to open a center for excellence today, or it should be after 10 years. Today we should open a center, and it should be center for excellence after 10 years of research, robust research, as sir has told us. And Arvind Mohan sir also targeted that particular thing. I propose that there should be a Jeevan Shakti University. Why don't we have, instead of public health university, we should have a Jeevan Shakti University, and we should look after the cancer care, device care, we should have the drug safety care, we should have the pollution care. So all these components should be catered by that particular university. Thank you, ma'am.
Thank you. Thank you, Dr. Manish Chaturvedi. It has been a very enriching session. Yes, ma'am.
When we are planning, center of care, when we are creating, so we have to think about the sustainability also. Like it should have a supporting system, like to do the gatekeeping function. Look at Delhi AIMS. Like it is so flooded that even what excellence, even normal care gets affected. So that way, center of excellence has to be supported by a, preventive care, the, subordinate hospitals where other things will be taken care of and filtered out. Gatekeeping will happen. And again, above center of excellence, it should have a collaboration with networking who will mentor them to retain that excellence and whatever excellence is created. So that way it has to be a tiered structure. And of course, preventive care, which has been talked about, that is the base, and that no one can fly without, touching the ground. So ground has to be there. Then only we can fly.
I think our panelists have stimulated so much thought in the audience that everybody is, I can see many people eager to ask or give suggestions. We'll circulate an email address where you can post your suggestions because due to lack of time, we also have a group photograph session and a concluding session. I would like to conclude the session now and thank all the. Yes, sir, definitely. ACS sir wants to come. So we still have to after your speech, we'll give a formal farewell to our panelists.
So I've been trying to move from panel to panel. So this is probably sequentially speaking the last, but actually it is very close to my heart. So I thought I will say a few words. Now, with due regard to whatever has been discussed here, because mostly I was not present here, I've just come. If you go to PGI, at least if you went to PGI when the old emergency was there, you would have found 4-5 patients on stretchers lying on the floor. वो नज़ारा किसी को याद है? जमीन पे इमरजेंसी में लेटाए हुए याद है? याद है तो हाँ बोलिए. हाँ, अब वहां पे 210 बेड्स की इमरजेंसी है. But it took time. It takes time.
I'm talking about 2014-15. And now I'm sitting in 2025. Today, Mr. Avnish Avasthi spoke about a quaternary care hospital. Do you think it will come up in 5 years? I don't think so. It will take at least 10 years to become functional and another 10 to become, halfway through to the kind of excellence that we want to have. Today, my ex-ADM, my special secretary and additional director PGI just messaged to me. He is unconscious and he is on ventilator in ICU in PGI for liver failure. Do you think such care was possible even in PGI 10 years ago? It was not. 3 days ago, somebody I know, elderly gentleman, he underwent a surgery of liver transplant in Max Saket. But I don't think 10 years ago there was liver transplant in Max Saket. So centers of excellence doesn't mean center of excellence doesn't mean a building. It can be a center of liver transplant within a hospital. It could be a center for a particular kind of, radiation for a particular kind of cancer. So creating new centers of excellence, ये जो आरेका ने subject devise किया है, she deserves credit because it says it is not just that, you'll create a new hospital. We have now so many medical colleges. At least 4 or 5 of them can be selected. I went to Postgraduate Institute of Childhood. I met one lady, I forget her name, she is from South India, Kerala. She is doing bone marrow transplant for very small children. The normal procedure will cost 24 lakhs. We in PGICH, which is a unit of health education, medical education, are doing it for 7 lakhs. We have managed it. So it happened because a very, very persistent and I would say obstinate director, he put his head down that मैं ये करके दिखाऊंगा. He found the right kind of doctor. Her husband had certain job. She wanted to be in Noida, being from South India. She had the skills. So bringing people together, the equipment together, will create the right kind of center of excellence. That is one. Secondly, I think some of my officers present here might remember they were sitting with me. One principal secretary came and he admitted that one of his children is autistic. Why not create a center or a UP Institute of Autism? So when I mentioned this to higher authorities, including our advisor, Mr. Avnish Avasthi, he was delighted. He said, this is the need of the, because there is such a big, the word I learned was spectrum that an autistic child might have. So these are just ideas, अगर 24 करोड़ के राज्य में हमारे पास अभी भी ऑटिज्म के ट्रीटमेंट के लिए लोगों को गुड़गांव जाना पड़ रहा है, दिल्ली जाना पड़ रहा है. Why? I agree that everything should not happen, cannot happen in Lucknow. Something can come up in Kanpur or Agra, या प्रयागराज. लेकिन कम से कम स्टेट में हम सोचें उसके बारे में. Similarly, new centers of excellence in public health. A very good, आपने क्या बोला, जनशक्ति, जीवन शक्ति, excellent. डॉक्टर चतुर्वेदी ने, उन्होंने एक नया नाम दे दिया है. So I will work on it. But definitely today we don't have the UP equivalent of PHFI. Why? Why we don't run? And then I don't want PHFI, public health courses to run in every university. This is the Apex University. Here we will have public health. Okay, अच्छे courses. Best in class. Third is, please see the heading of the subject. New centers of excellence in hospitals. That is already happening. And I think Dr. Mohan, Arvind Mohan, was arguing for that. That is happening. Centers of excellence in hospital in the face of or in terms of hospitals are already coming up. So I think I just want to announce one thing, that whatever this eminent panel suggests and this committee of wise people suggests, we will allocate one page to your one full page in our report. 9 sessions, 9 pages. That is all I can give you. In that, you tell me what you can do by 30. We want an institute on autism or whatever. Okay. Today you go to Center for, what is that, spinal injuries? है ना? Spinal injuries, Delhi. लगता है मेला है. You go to PGI, it is like कुंभ मेला ना कॉरिडोर में. पुराना जो इमरजेंसी के पीछे कॉरिडोर था, you have to push your way through. I have seen that. Go to Balrampur, see the condition. As MD NRHM, when I went first time to Gorakhpur, pregnant young ladies, they had to be pushed so that I could enter the women hospital. Itni bhid. There is so much of pressure, footfall. So what I'm trying to say, that we need to expand our existing facilities, create centers of excellence. We need to create new institutions, and we need to bring in new hospitals. So har jagah, the key word is excellence. So one page, what is to be done by 30, what is to be done by 36, what should have certainly happened by 2046. That you give me. All of you who are here, Areka will announce a mode of communication. Please feel free to give your suggestions. Sorry for taking so much time.
Thank you, sir. Thank you for your input, sir. You have been the guiding force behind the session. Please be seated. Dr. Shipra.
Thank you, sir. Thank you, ma'am. This was a very wonderful session. And on behalf of the Department of Health and Family Welfare, Government of UP, we extend our heartiest gratitude to our esteemed panelists for their invaluable insights and guidance during today's deliberation. I would like our Special Secretary, ma'am, to please give a thanks-giving memento to Dr. Manish Chaturvedi. Dr. Arvind Mohan. Dr. Arvind Mohan. Dr. Harsh Sharma. Dr. Subita Ghosh, ma'am. Dr. CM Singh, sir.
Thank you so much, all our panelists. I now request you to join us for tea, and then we have a group photograph session in the lawns adjoining the plenary hall, Rijrama Hall. We have a group photograph session after tea, and the concluding session in the plenary hall. Thank you.